कोई ना जिसका बड़ा नाम होगा डॉक्टर जिनका बड़ा नाम होगा ऊपर नीचे हो जाएगा। मुझे 2 शॉट नहीं डॉक्टर विचार को सुब्रमण्यम नाम हुआ है डेट आ गया तो स्टैंड ही नहीं लगा ऊपर बिना बस प्लेट
कैमरा लगाओ।
चंदन भैया ऑन कीजिए तो कैमरा ऑन कीजिए ना।
मैं लगा कौन करिए
स्टैंडिंग स्कैनर वाला नहीं
बोर्ड है यहाँ पहुंचने वाला है का
बैटरी यहाँ से नहीं ले
चार्ज नहीं है, दोनों चार्ज नहीं है। हम वो लाए हुए हैं तो वो भी चार्ज नहीं है।
आप जो लगा वो चार्ज नहीं है
ना, वो रखल है वो चार्ज नहीं है।
ये चार्ज नहीं है
नहीं,
चार्ज नहीं लगा
ऑन होता है अपने बंद हो जाता है।
कितना परसेंट
ये 60 था, अभी 35%।
अभी लगाइए चेक करिए।
हाँ बताइए जल्दी से स्टैंडिंग स्कैनर वाला चिपका के लगवा दो बाहर
ना बोर्ड दौड़ा डाल दे डॉक्टर।
अरे ये वो यहाँ आया हुआ है उसको चिपकवाओ सामने में लगवाओ पहले स्कैनर वाला। ओ
गया
हाँ
देखा
ठीक एसी में कर दिए।
अच्छा बाबूजी ले चलो
कैमरा
क्या
कैमरा स्पीकर में नहीं अरविंद जी का
मनुआ कर लेगा तो चिपका हुआ है स्टैंडी का उसको लगाने के लिए लिफ्ट के बाद में स्टैंडी लगवा
ऑन है
ऑन आएगा
कहाँ पहुँचा?
आता वन थोड़ा हो जाए दूसरे लोगों फोन पे ऊपर ही था दे दिखो वायरलेस लगाते हैं अगर लेकिन वायरलेस तो वायरलेस तो हमको सही है ना छोड़
से निकाल मुझे दोस्तों
तो आपने वीडियो नहीं फोटोग्राफ हाँ चलो वो स्कैनर वाला कोडियम वाला स्कैनर को
स्कैनर प्रिंट हुआ रोहित जी स्कैनर प्रिंट हुआ
स्कैनर वाला एक तरफ लगवा दो
एक दूसरे ना
और बाहर को लगा दो उसके अलग साइड ये
काम नहीं आता
रोहित जी
काम
कहाँ है फिर अरे यार उसको कॉलिंग मंगाया उसको क्लिक पर जहाँ जहाँ मिटा देना है आया हुआ है और मैं मंगा लिया उसको
कैमरा निकाल के आइए ना
हाँ उसको जो बिल पर उसी पे दाग लग रहा है
चेक कर लेता हूँ ना
कौन है कंप्यूटर के बाद कॉलिंग आ गया हाँ ये भाई तू अब कटाके मत कर
देखो तो आया ही
क्या बोल रहा है यूट्यूब वाला नहीं दिया था अरे यार तो दिक्कतें हो यार वही तो मांग रहा है तू यार अब देगा
यही छुट्टी हो जाएगा
तू तो बोल रहा है कि दोनों दिया हुआ है और प्रिंट कराया हुआ है
कहाँ से ऐसे ले जाएंगे किनारे किनारे टेबल का
तो पहले भी देना चाहिए था
हाँ बता
बताओ वेन्यू काम शुरू होने वाला उस समय तुम दे रहा है क्या
कनेक्शन मिलेगा उसके बाद ही ना सारा कुछ कर देंगे कुछ कुछ बाद में
मुझे लगता है यूट्यूब वाला भी जो अभी तो अभी दे रहा है स्कैनर जो प्रिंटेड नहीं हुआ है बोले वो बहुत बड़ा है क्यों भाई और लग जाएगा विवेक दिया है तो उसमें दो वो फोटो वाला है वो यूट्यूब वाला है यूट्यूब वाला बोल रहा है अभी दे रहे हैं सही में ये सलाह हम क्या बोले आओ तुम यहाँ
आ गया
एक ही बार भेजने का तुरंत आ जाता दोनों
काम शुरू होने वाला तभी स्कैनर दे रहा है
हमको भेजो
अब एक ऊपर लिखना है फॉर यूट्यूब लिंक
फॉर यूट्यूब QR कोड
देखो यहाँ देखो पहले समझो हमको कभी समझा रहा है ई करेगा ना
लिखा हुआ है सब कुछ
प्रिंट करना है ना
सब लिखा हुआ है
भेजो पीडीएफ भी भेजो गए बाहर पीछे वीडियो में खड़ा हो रहा है
इसको लोग खराब क्या है?
9 बजे हम बोर्ड बिठा देना बैटरी चार्जर नहीं कर रहा है, कैमरा पर कोई ध्यान नहीं देता। सही बात है, तुम भी व्यस्त रहते हो, फोन किया तुम फोन नहीं उठा रहे। छोड़ना, इतना याद रखो। कोई काम में लगता है क्या?
हाँ तो ये काम आया था तो मैंने
कौन देखेगा? अभी जब तक स्कैन नहीं करेगा तो देखेगा कौन? कर ले दो,
मुझे तो याद है ना भाई, जल्दी बता रहा है।
अपलोड हो जाएगा। बंद
हाँ, ये बंद हो गया, बोलो था वो एक तो
क्या है
एडवांस गेन कोड
दिखा दी।
सब तरह से रहेगा।
चाहिए
मैं व्हाट्सएप पे तुम्हारी गया हम खोले में बैठे में व्हाट्सएप खोल के देखो मैं
दूसरा नंबर तो वहाँ पर भेज रहा होगा।
नहीं उसी को भेज बस तो
देखो आपका काम
कट कर दो, नहीं उतार दो। आज रात को
काम कराई मुश्किल आती है।
देखिए तो डाल के
आप फोन
ये बोल रही है उल्टा करके नाप लेता है, एक्यूरेट भी काटता, उल्टा करके नाप ना। खराब बुद्धि दे। अरे क्या उल्टा करके सीधा उसमें करा, नाप लो, एक्यूरेट वहां पे काटो, हो गया। अब करो,
लेके आ जाओ अंदर।
तुम मत काटो गौरव, तुम छोड़ दो,
निशान लगा रहे हैं। मेन दरबार लिख लो, दरबार में सुनना लगा दो
रहेगा तो पर क्या दिक्कत है?
कोई दिक्कत नहीं
और अच्छा है,
खराब लगेगा।
वही ना कटाकटी कर रहा है। तीन को स्टैटिक प्रिंट कराना जी,
चार को मोदी है।
हाँ ठीक है, ऊपर डालो, कोई दिक्कत नहीं। फूड एरिया भी है, आज का फूड यहाँ है, कल का फूड वहाँ है, जाके देख लीजिए, जाके ढूंढ के फर्स्ट फ्लोर पर थोड़ा सा एक्सटीरियर करिएगा, करवाना होगा में काम हो रहा है इसमें। और ऊपर भैया मेहमान हमारा जाल मारेगा, बोल ले जाएगा, काम है, साथ बाइक से या गाड़ी से दौड़ ले जाएगा।
काम कर गया है ना, इसलिए लगा।
इसमें आपको तो नहीं ना दिक्कत है, ये जो लगाया है फ्रेम में।
ए भैया हेलो चेक आ गया, देखते तो
हेलो चेक चेक आ गया।
नेट पूरा लगा
प्लीज ज्यादा हिला डुला नहीं लगना, ये भाई नहीं कभी करने लगा तो आदमी बुला लो, कोई दिक्कत हो रहा है तो टेढ़ा हो गया, नट लगे टाइट करना होगा, रुको बुलाते हैं।
चंदन है, उसको बता दीजिए चंदन।
हाँ भैया
अरे साफ करने आया है टाइप करवाना मनु को लेते हुए वो डीडी कब लगाएगा?
अच्छा नागरिक कार्ड कर रहा है एवं नॉर्मल का नंबर दे रहा है तुमको, ठीक है?
क्या है उसके बाद
हेलो
कॉल करेगा तो बता
जब
दो।
करिए तो गया
वो छर लाया
जूम करिए दूसरा
पहुंच रहा है
रेलवे सेट कर दे उसमें,
कभी
रेलवे सेट कर दे।
उनको पता
लड़का कॉल करेगा, बोला कि निकल गया है। हमको ही भेजना, उसको भेजना। तो पहला दुकान जाओ तो हम बताएंगे।
ये इतना सा लेके रहिएगा। बस 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 बहुत
ठीक है,
ठीक है।
ठीक।
लाइट देख लीजिएगा अपने हिसाब से।
लाइट इतना ही रहेगा,
लाइट नहीं भरेगा।
नहीं फेस लाइट नहीं है आपका ना।
देखो छोड़ो नहीं, इसका हो जाना हो जाएगा। नहीं हो तो भरेगा नहीं। क्या है उसका वो भराओ, डीबी भराओ।
कितना
डीबी खोल देंगे तो फिर अच्छा नहीं लगेगा, गेम दिखेगा।
ना दे दो
जब लाइट नहीं रहेगा तो फिर डीबी खोलना पड़ेगा।
पशु में लाइट लगाने के लाभ बोल
देखिए आप
अब चल पड़ेगा।
हाँ थोड़ा सा कम करो।
ठीक है।
घूमना नहीं आ रहा है, लेकिन दुकान कर रहा है। नाची घूमने रोड
वो इसकी पकड़ा
ऑफ कर देगा भाई तू डिस्काउंट देगा
देखिए क्या यार
उतना बजे तक डिलीट कर देना जब शुरू होगा
ऑन करके देखिए ना।
अपना कोई लड़का है
आखिर हम यहाँ बैठा लेंगे
पटना में आता है।
आपके लिए 6,000 में लगा देंगे। पटना को जरा बताइए क्या है,
दे दिए
काम मना
ईच लिखा था तो छोड़ दिया।
कर दीजिए काम कर दी बैठक हुआ लेंगे 2-3 जगह तो सब ना रिव्यू तो मुझे नेशनल दे रहा है उसका बोल सब रिलेशन अच्छे रहे, आएंगे जाएंगे बैठेंगे काम
हमरा तो
लगा देगा कर सकता है।
बॉडी पे पैसा लगता है। हम तो रहे लाइटर सर महीना
तो आज हो रहा है
एगो को जो स्कैनर
ब्रेक
एगो मतलब एगो छोड़
महीना आ जाता है। पूरा मेरे पास जिला से
फटाक के लिए एगो है एगो फ्लैश
नहीं वो अभी तब ये बना
चार पीस चाहिए।
जो अभी गौरव दिया है
अभी जो गौरव दिया वो
2 क्वेश्चन साथ में
जैसा सरकारी कंप्यूटर लगल तो अभी करे लगता है।
हारेगा था
घावड़ा बोले क्या बात है मामला मुझे पड़ता है उधर फोन के तो रिस्पॉन्स नहीं देते वो काम में थोड़ी रखा था सबसे फोन में ज़्यादा ईगो वाला आदमी तो मेहरबानी करोड़पति की हो तो हमारे तो है घर है क्या है हमारे लिए कौन सी हमारे लिए है तो सारी मुझको काम हो रहा है
जा हम देते हैं बड़ा बोलेंगे
करना होगा मुझे
तू जा हाँ तू जा
हम बोले तो सुना क्या है ना हम 3 मिनट जाने दो 3 मिनट जाने हमारा पता ना है
कहाँ
वैशाली में
हाँ कौन भुलाएगा क्या आदमी हम नहीं भुला देंगे
मतलब रो क्या है तुम
चलो
रेडी गिरे
रोहित भाई जल्दी आना
ठीक है
हाँ
ये रख लीजिए
आगे वाला निशान होता है
आपको मिलाना वैल्यू बढ़े हुए ठीक है
सनम बहुत अच्छा
चलो
उसका तो काम सुना काम आ जो ही बनाना खाना बनाया है वीडियो का जो हाँ अभी मौसम बना सब कुछ दे दी हम फोन भी किए कि बोल भाई आ रहा है ना हाँ हाँ आए ना आया पर शाम को देख रहे हैं हम नहीं आ रहे हैं तो मेरा काम वहाँ पे नहीं हो रहा कोई और आजकल वो सूरज सटा हुआ है देखो कल सूरज नहीं था हम काम कर रखे यहाँ पे देखो यही सूरज कल वही काम कर रहा था
ये नैकन सबके पकड़ता है दूसरी को साइड के काम करा के पैसा रख लीजिए बस विधायक विधायक वाला पावर
बढ़िया विधायक तो समझ बना लीजिए
करना ही होता है अभी तक तो नहीं
हो रहा है
अभी पटना में
मिला नहीं मिला रात में आए वहाँ पर बोला
सोनुआ से काम करा से पहले रहे से सामान लेकर 75,000 रुपया किसी रख दे
कुछ खाया बन दो यार
अभिषेक पानी नहीं
याद है ना पानी तो
योग अपने आप हो
कहाँ चले खाते
सब बड़े मामा है
कहाँ से लाया किचन में
चार्ज में 100 रुपया एक्स्ट्रा भाई के पीछे खर्चा हो जो है खर्च नहीं ये 25
सरकार साथ देगा 21 कर देगा तो जाएगा
स्टैंडिंग यहीं पे लगवा
लड़ाई
लड़का भी आया था ना
मोबाइल जब झगड़ा करे देता
अभी सब ठीक ठाक चल रहा है
ये क्या रहता है
ओपन जगह
अकेले वर्क के
चंद्रशेखर वो लोग गया घर पर
वाला का फोन है तो ठंडा है
आज कितना प्रोसेस लगेगा कल तो
फिर बिना पानी के हम लेकिन उसका अलग हुआ है टीचर जो है अनिल राज के काम को कीजिए वाला है आपका ये साल
फूड कूपन भी आ गया
जेल पैसा वाला जेल में क्या
इसमें जी को वो ब्रोशर और फूड कूपन दे दे दूसरा सर्टिफिकेट एक्स्ट्रा बचा हुआ था जो 2 पीस वाला था वो भी आ गया नहीं एप्लीटी से नाम तो कितना नहीं है कल कितना बजे 4 बजे तक है 4:30 अभी कितना बजे शुरू होगा 4 तो जनरेटर का बंद करवाना ना आज सुबह जल रहा है जलने आज से चलेगा कितना बजे तक 30 से
कैमरा के पीछे बैठल से खबर तो अच्छे आगे
चलो कोई बोलता है
तो सब कुछ लेकिन मिला
दो सौ आ इसको अपलोड हो गया
चैनल
अभी तो आप
आपके पास है क्या शेड्यूल
लगेगा क्या बोल चला
यहाँ मैं आपको रिपीट तो पता नहीं तो मंगवा लीजिए पहले कुछ था थोड़ा बहुत चेंज हुआ था मान लो कि आपने मैंने दिया गड़बड़ हो गया तब लगा
अपने सिखा लिया तो
मंगवा दीजिए ना मुझे
सिखा के लाइसेंस बनवा
तुमको भी चाहिए
हाँ
नाम बताओ
स्पीकर नेम चाहिए ना
आपके नाम से
टाइप करने वाला
हाँ आपका हो गया रवि जी
नहीं मेरा भी स्टॉल चला तो हो गया तीनों हो गया हेलो शेड्यूल जो है वो फाइनल हो गया है तो एक बार मुझे शॉप को भी व्हाट्सएप कर देंगे क्या कोई बात नहीं
हाँ कौन सा पीछे क्या
लॉट्स जी है यहाँ पे लेकिन वो बता रहे हैं लास्ट
पीछे भैया पीछे वाला गेट पे वो चढ़ लेगा एक बार
जो शुरू से वही है क्या पीछे
मेरे पास जो है वो शाम को 6 बजे से थोड़ा जो है वो
चला रहे थे फिलहाल कैसे
चेंजेस ही ना है
एस्केलेटर पानी पीना ब्रो
मिल गया सर भैया
आकाश
मतलब तो सब तो नहीं चाहिए, मतलब नीड होता है, सब तो नहीं चाहिए,
वो भी आगे नहीं
इसका मतलब समझ, सब तो नहीं चाहिए फिर डीप
फोन करेंगे
डीपली बताया, डीपली आपको बताया। चलो कुछ आदमी है, सीनियर बहुत बड़ा बैठा हुआ है, बहुत है, वो थोड़ी है बहुत मेरा क्या सभी घर तक कर ही पा रहे हैं। मेन आदमी बैठा हुआ है, फाइनेंशियल सीए से बात, हम लोग खाए पिए नहीं, क्या और उंगली करने जाओ दोनों करीब
कहाँ करे भैया
चप्पल से बना लो
एक बार फोन हाँ बोल
बताया था ना, डिस्क्लोज करें तो बोलेंगे, तो सब बजल है वो करके बात करता है।
दिल्ली लखनऊ
आप भेजे नहीं आशी
देख रहे हैं
वैसे लखनऊ से है 18 तारीख 9 बजे
सामान लेके
कलकत्ता में डॉर्मेट्री है एयरपोर्ट पे, ठीक है। हम जब भी वहाँ पे है, मेरा जगह पे मतलब हम जैसे रहे हैं, तो डॉर्मेट्री जैसे है एक दिन पहले बुक कर लेना, कहीं जाने की जरूरत नहीं है। और अगर होटल लिया तो समझो कि एक्स्ट्रा 1200-1500 लग जाएगा, 750 के लमसम में तुमको डॉर्मेट्री मिल जाएगा। तो ये सुतना बहुत मस्त जगह है, कोलकाता एयरपोर्ट का अंदर में शायद 6 या 7 नंबर काउंटर पे बनता है, मतलब पूछ लेना किसी से बता देगा। जब तुमको यहाँ से चेकिंग गेट चेकिंग करता है ना, तो गेट चेकिंग कर देना, कोलकाता वाला बाहर जाता है जल्दी। देख लेना ऑनलाइन अभी सुविधा बंद कर लेना, जाके करना देखना ना क्या कर लेना। 2-3 बार रुके हम, मतलब जो मेरे जगह पे रहेगा उसके लिए वही जगह ठीक है, उसका वैसे करना है, ठीक है।
हेलो
इंदौर ही नहीं, जब भी जहाँ भी रहे, गोवा रहे, कोलकाता रहे, सब जगह रहे वैसी रहता है। जा रहा है कि नहीं?
पानी की
इधर वाला मिल गया क्या?
ये दोनों लाइन क्या बनवा नहीं अच्छा
अच्छा ठीक है, तो आगे दूसरा दिन
ये घर मिल गया खबर तो मिल गया ना भाई।
हाँ भाई, रात के
अब सारा एक साइड में ले लो भाई।
हाँ 16-17 अच्छा से ले लो तो
अच्छा हाँ बीडी लिखा हुआ, हमको लगा था PID है। नहीं ठीक है, 30 दिन है तो 15 दिन का।
सेकेंड हाफ से नहीं, फर्स्ट हाफ से चालू हो जाएगा। हम इधर से उन लोग के केवाइन में होने रहे
चेक किया तो एक बार देखो यहाँ आया।
क्लियर। जिसमें गाड़ी पढ़ना है उसमें पहुंचेंगे, जिसमें नहीं पढ़ना है उसमें हमको बता देंगे।
सर गुड इवनिंग सर, अभी हम करवा
बता दिया।
शेयर करना पड़ेगा जब तुम काम करेंगे
एक सेकंड।
उल्टा हो सकता है
आ गया, ठीक है, विजय के बाद
कनेक्टर करेक्ट खराब है
कनेक्टर
शेयर करो बोलते
अरे वहाँ जाओ, मेरे को व्हाट्सएप पे लिंक भेजा, सबसे नीचे वाला मी वाला में, मेरा नंबर वाला पे व्हाट्सएप खोलो। नेट मैंने अपना कनेक्ट किया हुआ अभी। हाँ, सबसे नीचे वाला हाँ, पूरा कॉपी करो और उसको मिनिमाइज करके विंडो आर दबाओ।
विंडो आ रहा है
हाँ, उसको कॉपी करके बाहर आओ, विंडो आर दबाओ। हाँ, उसमें पेस्ट करो।
इसको करते हैं
हाँ, पेस्ट करो, अब ओके करो। देखो फाइल खुल गया ना, आ गया। चलो इस रुक जाओ, इसको यहाँ से डेस्कटॉप पे आके सेव कर। हाँ, डेस्कटॉप पे सेव करो, डेस्कटॉप पे आ गए, उसको डेस्कटॉप पे सेंड, कॉपी नहीं है, डायरेक्ट सेंड करना, कॉपी करने का नहीं है।
शॉर्टकट भी बनता है ना शॉर्टकट
मोबाइल के कैमरा से कंपेयरिंग करें तो इसका पिक्सल और उसमें ज़्यादा, मतलब इसका अगर 15 मेगापिक्सल यानी 20 मेगापिक्सल तो उसका कितना के बराबर है एक एवरेज?
मोबाइल को ये स्पेशल
DSLR जो कहलाता है वही है ना? हाँ,
मोबाइल अलग हो।
नहीं उसका तो बिल्कुल तरह से खाली कहने का 50 मेगापिक्सल, लेकिन अगर 50 मिल जाए इसका तो कहाँ चल जाएगा।
हाँ,
कैमरे से स्टार्ट करने वाला है, कोई एजेंडा नहीं, बस मजे करो। हमारा नहीं
तो नहीं वो नहीं
काम लेंगे तुम्हारा भाई माना कि वो सब सुन लेते हैं उसका माना नहीं रोल मिलता है
अच्छा, आपको सबका एक स्लाइड मिल गया इंट्रोडक्टरी वाला इंट्रोडक्शन वाला स्लाइड सबका मिल गया, स्पीकर चेयरपर्सन का सबका मिल गया है। पहला का दिखाइए जरा कैसे डिस्प्ले करेंगे।
10 बाई 4 या 6 का ब्लैक यहाँ पे चैनल नहीं या 8
अरे सर सुपर हाँ ठीक है, एक बार दिखाओ
थोड़ा आगे कर
नहीं ना सर, पूछो 2 लाइन 4 लाइन भेज निकाल देते हैं सर।
या 10 फीट का है, 10 फीट का है।
सुनो ना साथ सुनो ना जरा सा सर का। हाँ सर को सलाम कियो सर, ये पहला हम लोग का TRMP स्टूडेंट पटना का इशू फोटो भेजे हैं सर, भेजे हुए हैं सर, लैपटॉप पे बना दो यहीं पे ले आओ ना सर से 2 मिनट बनवा लो। ये स्पीकर का है, चेयरपर्सन का दिखाओ। एक मिनट ये स्पीकर की स्पेंड ठीक है, उसके ठीक 5 सेकंड पहले चेयरपर्सन का दिखाते थे। हम बुलाओ ना, वहाँ क्या बैठे कौन कौन बैठे तो बुलाओ, तो यहाँ पे तो वहाँ क्या बैठे
सर एक ब्लैक पैनल बोल दिया यहाँ पे लगा दे।
सर बॉर्ड में ऐसे सर बॉर्ड नहीं दिया हुआ आपका
तुम बोल करवा दो इसको पहले करवा
पीपीटी का फॉर्मेट है ना फैकल्टी वाला फैकल्टी वाला भेज रहे एक सर कर रहे हैं सर
फोटो दे दे
हाँ दिए ना अशफाक को दीजिए हाँ सर
अरे आप सीनियर है आप
भेजिए अशफाक को भेजिए ठीक है उसी को बस करके सर का
प्रोग्राम है ना सर
उसी में भेज दे रहे हैं उसी पीपीटी में फॉर्मेट में 2 मिनट में बन जाए एक लड़का एक लड़की है सर तहसील भी आएगी सर उसे मिलवा देंगे हम भेज रहे हैं सर एक ये तुमको भेजे किसी और का है उसी में सर का बना दो अभी फर्स्ट ईयर का लगा दो
अभी तो मुझे हाँ
चेक कर लीजिए।
दिख रहा है जरूरी है ताकि गलत मत हो।
मैसेज आ रहा है। तो हमको एक सुनो ना, एक हाई करके भेजो।
भेजिए। क्या?
ठीक है, ये भेज रहे हैं। मैक्सिमम का भेज रहे हैं, धीरे धीरे करके तो डाल दे जाओ। बहुत का हो गया होगा, जिसका जिसका नहीं होगा
दूसरा पॉट हुआ
वो एक है, वो अलग है, वो एक अलग है। हेमंत सर कौन किए थे सर? 5-10 मिनट बोले कि लेट होता। चंदन ओपन नहीं है सर, चंदन जो करवाएगा सारा। करवाएंगे सर अपने पीएम के सर ये लाइफ पे ही हो जाता तो पीजीआई चंडीगढ़ नहीं हो जाता सर। प्रोग्राम कराएगा मास्टर ऑफ सेरेमनी। बुला दीजिए सर, उसी को शुरू कर इसीलिए तो एक कॉल कर लिया तो आइडिया
सर आज 10 साल पूरी आज
आइए सर। डॉक्टर ओपी मिश्रा सर हैं, ये विनोद सर हुए सर ने बड़े रिटायर किए हमारे बैठिए सर। ठीक है सर, आपके कैंडिडेट लोग आ गए सर। अच्छा सर ओपी मिश्रा सर आपका बेसिस देखिए सर। मीडिया वाले ऐसा लोग को कुछ बोले, जय मैंने कुछ बोले
बोला हुआ
हमारा सबसे ज्यादा उत्सव कराते हैं उधर संजीव सिन्हा बोले पूरा गाड़ी को लाद दो।
हमें तो लगा कि हमें देर हो गई है।
नहीं टाइम का है सर।
तो हम सुबह से लगातार काम ही किए हैं। एकदम पहचान में नहीं आ रहा आपका नाम
क्या सब ऐसे अच्छा
कम करो। हेलो हेलो, सुनाई दे रहा है पीछे? हेलो,
इसको डिलीट कर दीजिए।
दो टेबल लगवा दो, पानी का बात होगा वहां पे पीछे बोल
सुना ना
हेलो हाँ हाँ सर हम आए हुए हैं लोग यहाँ रहने से आ रहे हैं हेलो हाँ हाँ हॉल ही में है सर हम लोग बैठे हुए हैं सर बगल हाँ जी सर ठीक है
मेरा डर भी आ गया। हाँ सर, 4 बजे हेमंत सर खाली सर, हेमंत सर बोले कि 10 मिनट से देर होगा, लेकिन हम बोल देंगे 4 बजे।
पूरा काटे में चला तो नहीं है।
हाँ कम से कम भेजने के लिए। हेलो सर आप रही जी सर जी सर जी सर जी सर
हाँ हाँ
सर एक हेल्प करोगे? देखो ना मेरा नाम का
कैलकुलेट करना पड़ेगा।
एक बार
दौड़ जिम से तो लुप्त हो जाता है। हाँ भाई अमित, हाँ
है
रिजवान बॉस आज ही की कल है। हाँ जाएगा सर, आप यहाँ क्यों बैठे? अरे आगे आगे को दर्शन से मिला देना।
जवान टाइप चलिएगा हम लेकिन नहीं हमें भेजो तो दूसरा
आप बताइए
छः सात को भगवान का
वेलकम।
स्लाइड को तो स्पीकर के लिए रिटर्न मोमेंटम है या प्लेन मोमेंटम सबके लिए सेम स्पीकर चेयरपर्सन बहुत सेम। हाँ वही तो और कोना पर तो आज के लिए इस
मिले नहीं
PMCH का email ID
थैंक यू।
ठीक है, चलना एक बार अच्छा
नहीं सर्किल ग्रुप में ठीक से दे दो ना। वी आर स्टार्टिंग अनफॉर्चुनेटली वी आर स्टार्टिंग अरे
अरे क्या बात है, हाथ मिलाना बंद करने के बाद आधार हम हवाई कोई बात नहीं। 40 साल नौकरी करने के बाद भी ज्वाइन करने का मन करता है, कहीं काम जाएंगे तो हम फाइट होकर जाना है। जिंदगी का आनंद मंदिरी में है, चला मकान है, तो जगह में रहता हूँ। स्टार्ट शुरू कीजिए ना भाई। एक्टेड थिएटर स्क्रिप्ट पीरियड everything I just joined. नाम याद नहीं आ रहा। हेलो
फोन हमको आ गया आपका चलिए कॉल बनाए
हेलो अमित, फोन आया नहीं इसमें लिंक और
नहीं रजिस्ट्रेशन नहीं कर रहे हैं क्योंकि उस समय हम अवेलेबल नहीं है।
तो हमने देख आराम से आ गया ना। हॉटलाइन
आप अपडेटेड है, काफी अपडेटेड है।
तो
आप मतलब टाइम ही
पूरी जिंदगी खाना सोना पकड़ना खाना सोना
Good evening, everyone. A very warm good evening. भगवान बुद्ध और महावीर की धरती पाटलिपुत्र में मैं डॉक्टर चंदन आप सभी का स्वागत करता हूं। हम सभी यहाँ एकत्र हुए हैं आज इस शुभ अवसर पे एसोसिएशन ऑफ पीडियाट्रिक नेफ्रोलॉजिस्ट ऑफ कॉन्फ्रेंस 2025 मैं फिर से आप सभी का तहे दिल से स्वागत करता हूं। आप सभी को पता है एक छोटी सी किडनी, छोटा सा बच्चा और बीमारियां इतनी सारी। 2008 में ISD से हट के पीडियाट्रिक्स ISPN इंडियन सोसाइटी ऑफ पीडियाट्रिक नेफ्रोलॉजी का गठन हुआ और तब से लेके आज तक हर एक साल हर एक दिन बच्चों की बेहतरी के लिए पीडियाट्रिक नेफ्रोलॉजिस्ट काम करते जा रहे हैं। कोई भी कॉन्फ्रेंस तब तक अधूरा है जब तक वो साइंटिफिक रिसर्च उससे अच्छे ना हो। अगर हमारे नॉलेज में थोड़ी भी बढ़त ना हो कॉन्फ्रेंस के बाद तो वो कॉन्फ्रेंस सक्सेसफुल नहीं हो सकता। और इससे बढ़िया क्या हो सकता है कि पूरे हिंदुस्तान से पीडियाट्रिक नेफ्रोलॉजी के डिफरेंट विधा के लोग यहाँ पटना आए हैं और उनको चेयर करने के लिए जो भी हमारे पुराने लोग हैं जो डिवीजन नहीं हो पाया था वो सब यहाँ एकत्रित है। तो आप सभी का स्वागत है। कार्यक्रम को आगे बढ़ाने के लिए हमारे आज के पहले स्पीकर डॉक्टर गोपाल सर, प्रोफेसर डॉक्टर गोपाल सर से मैं आग्रह करूंगा सर कृपया स्टेज पे आए और इस सेशन को चेयर करने के लिए हमारे बीच आप कह सकते हैं हमारे फील्ड के विश्व पितामह प्रोफेसर डॉक्टर हेमंत कुमार, डॉक्टर US राय, प्रोफेसर डॉक्टर ओम कुमार सर एंड प्रोफेसर डॉक्टर पंकज हंस सर। मैं इन चारों को आमंत्रित करता हूँ स्टेज पे। डॉक्टर हेमंत सर किसी पहचान के मोहताज नहीं है पटना में और पूरे भारत में। हेड ऑफ फॉर्मर प्रोफेसर हेड ऑफ डिपार्टमेंट ऑफ नेफ्रोलॉजी IGMS पटना एंड PMC पटना एंड फॉर्मर डायरेक्टर गार्डनर रोड हॉस्पिटल, अवार्डेड पद्म श्री बाय ऑनरेबल प्रेसिडेंट ऑफ इंडिया। प्रेजेंटली ही द प्रेसिडेंट ऑफ एम्स गोरखपुर और सर का स्पेशल इंटरेस्ट पीडियाट्रिक नेफ्रोलॉजी में है, इसलिए सर का स्वागत करता हूं। ए बिग राउंड ऑफ अप्लॉज फॉर डॉक्टर हेमंत कुमार सर। हमारे बीच है डॉक्टर प्रोफेसर US राय सर, फॉर्मर हेड ऑफ डिपार्टमेंट नेफ्रोलॉजी IGMS पटना, सीनियर कंसल्टेंट और पटना में सर भी किसी परिचय के मोहताज नहीं है। आपका स्वागत है सर। हमारे बीच है डॉक्टर ओम कुमार, हेड डिपार्टमेंट ऑफ नेफ्रोलॉजी IGMS पटना एंड डीन एकेडमिक्स, ऑल्सो पास्ट वाइस प्रेसिडेंट ISN आपका स्वागत है सर। हमारे बीच है डॉक्टर पंकज हंस सर, जो प्रोफेसर ऑफ मेडिसिन इन PMCH एंड ऑल्सो वेरी फेमस मेट्रोलॉजिस्ट ऑल ओवर द बिहार। सर आपका स्वागत है। मैं आमंत्रित करना चाहूंगा डॉक्टर गोपाल प्रसाद सर। मैं चेयरपर्सन से रिक्वेस्ट करूंगा कि डॉक्टर गोपाल सर का इंट्रोडक्शन है, प्लीज सर।
Good afternoon, everyone. Dr. Gopal Prasad needs no introduction. He is currently professor and head of nephrology at Patna Medical College, and I invite him to just deliberate upon the topic allotted to him. That is, how is pediatric CKD different from adult CKD? That he is going to deliberate upon. Dr. Gopal Prasad, please.
Thank you, Chairperson, sir. And first of all, my greetings and welcome as well as thanks to all the dignitaries who have come over here, as well as all the delegates and faculties who have spared time to come over there to make this program a success. My topic of discussion is pediatric chronic kidney disease, how it is different from adult, because as you know, there are incidence and prevalence of pediatric CKD is not too high in comparison to adults, but they need special consideration because they carry some distinct features which needs a special address and a special care, because that has impact lifelong. So I will concentrate my talk to some of these special unique features which children with CKD present. Number one is the diagnosis, and after diagnosis, we come to the various etiologies, and if treatable, we treat them and we address the various risk factors associated with the progression of the disease. Second one is growth failure. This has very important psychosocial impact on a child, and that has to be taken care of from very beginning, before he achieves a age of 14 or 15 years, when already all the skeletal growth is complete and puberty has been achieved by that time, hopefully, which unfortunately doesn't happen because of delayed skeletal growth and overall growth failure. Second is the neurocognitive outcome, because most of the children fare poorly in school because of frequent absenteeism and not so much careful approach by a multidisciplinary approach. Unfortunately we don't have multidisciplinary care for such children. Cardiovascular complications and death are more frequent in children who have their disease at the very early age. And lastly, infection risk and vaccination, by giving them age-appropriate vaccination. And lastly, the challenges in preparation of such a small child for future, like kidney transplant, that is the best option. So, coming to the initial determination of GFR, which is very important part to stratify and accordingly manage the CKD, the MDRD EPI equation, which is usually seen for adults, is not appropriate for children lesser than 9 years of age. For them, initially, in 1976, SWORD formula was formulated, which was K is constant for age specific constant, multiplied by length or height in centimeter, divided by serum creatinine in milligram per deciliter. But with this, there were so many limitations because the children have lower muscle mass in comparison to adult, as well as because most of the time children have lower serum protein level, so there is need of correction method, and that correction method, because of Jaffe reaction, it is frequently there is overestimation. To overcome this limitation, bedside CKIV25 SWORD equation was given in 2009, where fixed constant of 0.413 was proposed. Because this method used standardized isotope values and mass spectrometry traceable in genetic method. Jaffe method was not utilized, which was earlier used. So approximately gives a correct value for children more than 2 years of age. For children below 2 years, the BSA adjusted GFR has to be given. That is a bit different because every time BSA has to be taken care of. After we stage the disease, we stratify the diagnosis of CKD. Earlier, K-DOKI was proposed in 2002. Later on in 2012, K-DIGO definition had some modification over the earlier K-DOKI classification. First of all, a moderate CKD was further divided into C3A and C3B. Secondly, it was defined as it included the GFR category of more than 60 or so, where there was a structural or functional abnormality in form of abnormal histology, abnormal radiology, tubular proteinuria or glomerular proteinuria. Any form of proteinuria was there included. And lastly, there was no mention about albuminuria, because as you know, albuminuria is not so important with pediatric population, and also most of the time the disease is non-glomerular, which I will explain in later slides. As you see, congenital anomalies of the kidney and urinary tract, that is CAPOT, this accounts for 50 to 65% of the cases. In approximately 20 to 25%, chronic GM, steroid-resistant nephrotic syndrome, and this posterior valve, they constitute 20 to 25%. The rest 10 to 15%, other ciliopathies like autosomal recessive polycystic kidney and Fabry's disease and Alport syndrome, they account for lesser than 10 or 15%. There are some risk factors which has to be seen and which has to be addressed early at the very onset of diagnosis and management. Modifiable risk factors are hypertension, and as was seen in ESCAPE trial published a few years back, a decrease of hypertension to less than 50th percentile had a significant improvement in progression as well as disease severity. Second modifiable factor is proteinuria. As I have said, proteinuria is a late manifestation of chronic kidney disease because usually the disease is non-glomerular. So if the proteinuria is there, hypertension is there, we have to take care with ACE inhibitor preferably. Obesity is not a problem in our part, but in Western countries, this is also a modifiable risk factor, just similar to adult one. Lastly, metabolic acidosis. I have just added because it is also a cause as well as a very important factor for progression of chronic kidney disease. So metabolic acidosis should be taken care of from very early stage. There are some non-modifiable risk factors and they need proper address. Number one is low birth weight and prematurity. As we know that there is development of nephrons is complete by 34 weeks. So who are born low birth weight or premature, they need frequent surveillance at least yearly for hypertension and proteinuria so that they can be adequately controlled. Recurrent UTI, especially in case of posterior valve, that is also an important factor to contribute repeated acute kidney injury, and they need special care in terms of frequent leukocyturia examination and long-term chemoprophylaxis. Failure of growth and development as well as associated puberty is a very commonly seen with children, and this is directly related to CKD onset. The earlier the disease is there, the more growth failure, skeletal deformities will be there. Most important cause is malnutrition, and that has to be taken care. Malnutrition has several causes like frequent nausea, vomiting, anorexia, and this test. So the practice guidelines KDOKI 2008 had suggested that the protein or energy intake should be minimum, should be rather more than, usually 100% is prescribed, but in such group of patients to maintain adequate nutrition, we recommend an energy intake of at more than 100% of the normal counterparts. Also, in case of smaller children, that is less than 2 years, there is frequent association of malnutrition because they are unable to take proper nutrition. Usually, we prefer to prescribe gastrostomy tube, and we recommend this whey-based rather than casein-based, because of preferably breast milk, because breast milk has lesser solute load, and whey-based has similarly that mimics breast milk and has lower solute load. Secondly, rather is CKD-MBD, that is mineral bone disorder or renal dystrophy. This is also because of associated metabolic acidosis as well as malnutrition. Then there is metabolic acidosis, and that has to be addressed very early. And this is because of this causes protein breakdown and severe myopathy. There is also associated suppressed secretion of growth hormone and insulin-like growth factor 1 as well as corresponding receptors. Then anemia is a frequent development with chronic kidney disease, and age-specific hemoglobin levels should be maintained preferably in the range of 12 grams per deciliter by adequate erythropoietin, iron, and wherever needed, IV iron preferably, because children do not tolerate oral iron usually. For anemia management, recombinant human erythropoietin is there, and they require larger doses in comparison to adults because of several non-hematopoietic receptors, and so there is more need of erythropoietin in children, more larger doses. So that has to be addressed. Then thyroid dysfunction with advancing CKD staging, there is thyroid hypothyroid, and this contributes to growth failure. So that has to also be replaced with adequate replacement therapy. Hypertension has also been a very frequent accompaniment with progressive CKD, and this has been seen in 40 to 50% of children with a stage 2 to 4. And when ESRD develops, its incidence rises to 70%. In one CKID cohort, it was seen in 35% of children had masked hypertension. So, in addition to clinic BP monitoring, a BP monitoring at home also should be encouraged, so that if there is mild hypertension, there is every chance of hypertension progressing to cardiovascular morbidity. Cardiovascular complications are always associated because of anemia, hypertension, and acidosis. So, in contrast to adults, where we found more coronary disease as a marker of cardiovascular disease, in children it is quite different. LVH is the more common presentation, and it has been seen in 50 to 75% of children who are on dialysis, and it has been seen in renal allograft recipients in the range of 50 to 67%. This LVH precipitates fatal arrhythmias, systolic and diastolic dysfunction, and so cardiomyopathy also, and so there was a record of more than 100,000 times higher risk of severe death in such type of CKD patients. Then there is infection. Infection is a very leading cause of death in children other than cardiovascular morbidity. So age-specific vaccinations should always be encouraged. Annual influenza vaccine should be given. Hepatitis B vaccine should be advised, and the dose is same as adult one. And if already the patient is having vaccination, a antibody titer should be measured. And if it is lesser than 10 units, we prescribe subsequent reinforced dose of this hepatitis B vaccine. And for pneumococcal vaccine, because pneumococcal infection is common, especially if the child has nephrotic syndrome at early age, then 23-valent polysaccharide pneumococcal vaccine, followed by, after a gap of 8 weeks, 13-valent pneumococcal conjugate vaccine, so that the immunogenicity is complete against pneumococcal. Live viral vaccine is avoided. Then lastly comes the step of preparing for kidney failure. 4-arm veins of non-dominant arms should always be advised not to puncture or not to take blood pressure. Avoid central line in subclavian vein because that may worsen the edema, ipsilateral edema, as well as this will further block the future outcome of fistula. Preemptive kidney transplant is always recommended because that helps to establish the growth and puberty. Urologic consultation should always be taken, and if the bladder dysfunction is there or recurrent UTI is there, that should be taken care of by treating pediatric nephrologist. Peritoneal dialysis, especially CCPD, is better advised for children because child has freedom in the daytime. Transplantation is delayed until the child achieves 8 to 10 kilograms of body weight, so that after that time the vascular access is achieved. So in summary, pediatric CKD is relatively uncommon, although uncommon, but sequelae have lifelong impact. Silent nature necessitates regular clinical surveillance to address modifiable as well as non-modifiable risk factors to preventing the disease progression. CKD stage appropriate and stage appropriate vaccination should always be advised. And unique consideration should be paid for optimizing skeletal growth, brain and neurocognitive development, cardiovascular health, anemia and hypertension. I have already briefly discussed all these issues. And timely and appropriate preparation for kidney failure, especially kidney transplant, is the best option. Thank you.
I think we'll take the question after the next lecture because topics are correlated with each other. So I will invite for the next lecture Dr. Darshan Rangaswamy. He is Professor and Head of Department of Nephrology and in charge of Division of Pediatric Nephrology in the Sultan Medical College Hospital, Manipur. He has a special interest in the pediatric renal transplant for nephritis. He has more than 50 publications related. The topic is current guidelines on the pediatric CKD management in nutshell.
I would like to thank my previous speaker. The initial pediatric chronic kidney disease. This helps my talk go smooth. Just to start with, as I said, the incidence is low, the prevalence is low, but it is rapidly increasing, mainly because the survival of very low birth weight as well as small for gestational age kids, as the survival increases, the incidence of chronic kidney disease is also increasing, mainly because of low nephron number as well as As Homer Smith said, one of the greatest organs which have contributed to the evolution of man has been the kidney. And I think more focus for pediatric chronic kidney disease over the next few years will make a healthy adult probably. So the elephant in the room has been addressed by Sir. The incidence of chronic kidney disease has been progressively rising in children, and definitely we know the cause for it because of the survival of very low birth weight. And the incidence is about 1 in 10,000. I'll try to skip some of the slides which have, not to make it repetitive. I think Kerigo came with a heat map and which clearly tells you what is the risk score, low, high, as well as the intermediate risk. And here what they changed is, since my talk is mainly on update on the management of pediatric chronic kidney disease, I will not well into the previous management issues. I will only talk about the updates. So one thing what we need to focus is in the classification, the description of chronic kidney disease moves from what is the cause for chronic kidney disease, what is the GFR, and now albuminuria has been added, and that's how the CGA classification has come in place. The more importantly, in pediatric population, what is more important is the green color which is marked for the adult population turns out to be yellow or orange for pediatric population. Someone who has a GFR, a persistent GFR in the range of 60 to 89 is likely to develop a progressive chronic kidney disease and doubling of the creatinine over the next 10 years. So it is not green, probably it's going to be a light yellow or an orange over the few years. So this is one change in pediatric. The second thing is, as the definition itself says, there is either a structural abnormality, so you do not wait for 3 months in pediatric population, we know that. If antenatal scans have already identified an abnormality and postnatal scans the abnormality, first is we do not have, especially dysplasias, aplasias, we don't have to wait, especially if it is having an impact on the life of the kid. So we don't have to wait for 3 months to declare the child as chronic kidney disease. The other thing about albuminuria and GFR doesn't hold good in some of the CKD population because most of them have tubulopathies and diseases like Barters and Dents. They have implications of life, and that is the reason they, even though without a decline in GFR or albuminuria, you can still label them to be having a chronic kidney disease. So, just to, after just going through the changes in the heat map, I'll just go through what Sir had already told. There are a few considerations and unique challenges while we are thinking about management. One is the age-based assessment of kidney function. There has been changes in this field over the last decade. Also understanding the disease trajectories and supporting their growth. So, in my later slides, I would talk about a couple of minutes on understanding the disease trajectories, why etiology is very important in kidney disease in children. Also, as the age matures, the urine protein creatinine ratio starts coming down. This is mainly because the neonates have a poor glomerular and tubular protein losses are higher in them because of the immaturity of the tubules. But as the child grows, more muscle mass, the denominator increases. So the UACR or the UPCR decreases, and by the age of 2 years, it is less than 200 milligram per gram. The next thing, as I already spoke about, is the GFR less than 90 should be flagged as low, and if it is persistently below 90, there is a chance of 50% decline in the eGFR over the next 10 years. While talking about the management issues, we need to also consider some of the unique considerations such that we know that CACUT forms the majority, so urine output is relatively preserved unlike adults, and so that's the reason the progression is also much more slower in children in CACUT, and this is actually an advantage for us in managing as pediatric nephrologists. It's an advantage for us, a slower progression of kidney failure in most of the pediatric kidney diseases, and also having a good urine output is, we need to take advantage of that scenario. Also, there are some delivery of care challenges which we need to have. Age appropriate, especially with protein requirement or drug dosing. It is all age appropriate guidelines we need to follow. Also, we also need to look into the caregiver education. It is not just the patient himself who is going to take care, it's the caregiver's burden which we need to share. Sir already spoke about growth and pubertal issues. I'm going to talk about how the trajectories change in puberty. And the APNEICON-2025 guidelines, which mainly focuses on the latest guidelines of APNEICON-2025-24, focuses on the pediatric aspects, and they talk a lot on the transition clinics. So transition clinics in the developed world is a big time. There are separate consultants who look after the adolescent and transition clinics, and they are the ones who communicate with the adult nephrologists, and there is a very smooth pathway of kids are being transitioned to adults.
I spoke about how the disease trajectories change with puberty. One of the reasons for reasons for change in the disease trajectories in the pubertal child is because of the increased somatic growth in the puberty compared to the nephron compensation, and that is the reason there suddenly can be a 10 times the decline in the GFR. There can be a 10 times decline in the GFR. So this is some things which we need to consider while managing children with chronic kidney disease. APNEICON-2025 gave a screening algorithm where this is mainly for children about 2 years of age. You need to look at their GFR. I'll speak a minute or two on the how you estimate GFR. Measured GFR is the best, but we cannot do it regularly, so we have the estimated GFR, and also the reliability on albumin creatinine or protein creatinine ratio, and also some other markers for kidney damage needs to be screened. And if it is persistently below 60, or if there is any of the other positive markers, you need to closely follow up them every 3 months and look for evidence of chronicity in them. And you need to refer them to dedicated pediatric nephrologists. The APNEICON-2025 also talks about the transition plan and how each age has different needs. For the children, the need is weight-based or body surface area-based drug dosing. As Sir spoke about neurocognitive development in pediatric population, we need to focus on that. And as we go to the childbearing age group of women, the requirement changes, the consideration changes. So all through the age, there are special needs when it comes to a chronic kidney disease patients. Our focus is in the first 3 or 4 age group, especially the neonate to the adolescent age group. So before we start managing kids, we need to make sure that we thoroughly assess a good medical history, developmental history, antenatal history, and also if there is a genetic possibility because of in one organ, try to explore if kidneys are also involved. What kind of a formula do we use? This is where I think there are a lot of debate. I think most of the health workers now use the chronic kidney disease under 25. More importantly, what KDIGO stresses here is not about what formula you use, but what is the assay you are using. Because if you are using an enzymatic assay, then it is much more reliable while using a GFR. If you are using still a JAFase, there are too many drug interferences like cephalosporins can interfere, bilirubin can interfere with the measurement assays. So not reliable. So also KDIGO talks about using 2 formulas, either 2 markers, cystatin C as well as creatinine whenever you are calculating. And this is the CKD under 25 formulas which we use both. So take an average of 2 markers, not just based on a single marker whenever possible, but most often in India we only rely on the creatinine, and that too is the JAFase method. The second thing is creatinine in certain scenarios like sarcopenia, spinal cord injuries are not much reliable where the muscle masses are low. But whenever you are use a standard traceable to IDMS, what spoke about. With cystatin C, again, there are certain factors which can impact like steroid use or hyperthyroid, all these, or cancerous states. That is the reason better to use an average of cystatin C and creatinine while using GFR equations. But practically in India, we can only use Schwartz or modified Schwartz. The reason because we still use JAFase in most of our bedside creatinine assessments. I'll not talk much on this. As age progresses, the GFR also improves, and by 2 years of age, we can have an adult GFR, and any change in the standard deviation, even a single standard deviation change, points towards the development of a chronic kidney disease. To summarize, in terms of measurement, estimation of chronic kidney disease, KDIGO said that laboratories should be well equipped to use the enzymatic method, especially in neonates where the interference is more with the JAFase testing. Always make sure that majority of the centers are using the same estimation formula, because in your center, if you are using enzymatic and if the child goes to a different center, they are using a Japanese method. Obviously, the GFR is going to change based on the change in the creatinine. GFR less than 90 is a flag sign, red flag, and always use validated equations which has been validated in your community and not in the Western population. Currently, there is no such validated equation in Indian population. There is one in, especially in the pediatric population. There is one in China and one in Japanese study, which we can actually incorporate. Coming to the albumin protein creatinine ratio, in pediatric patients we can use both protein creatinine ratio or the albumin creatinine ratio, but make sure that if the patient has a positive dipstick, or if a patient has a positive proteinuria on a reagent strip, make sure you do a quantitative estimation and not just a semi-quantitative. Even if you have measured a UPCR and if it is high, you need to do a UACR. The reason is because you need to characterize the type of protein. Because in children, tubular proteinuria is very common and you are going to get confused whether it is albuminuria or proteinuria. So you characterize the proteinuria by doing a urine albumin creatinine ratio. The descending order is always have PCR and ACR as the first choice, and if not possible, then a reagent strip which is automatically read. And use more accurate methods for albuminuria estimation. Immunological assays are preferred, and an ACR of more than 30 milligram per gram in a midstream early morning sample is what should be reliable. So if you do an afternoon sample, make sure you repeat it in a morning sample if it's positive. Second thing, as I said, in puberty there can be a rapid progression of our kidney disease and of the pediatric kidney disease. That is the reason you need to more frequently monitor. The ideal guidelines is CKD stage 1 and 2 you monitor every yearly, stage 3 monitor 6 months, stage 4 3 months, stage 5 every 6 weeks. But in puberty you monitor more frequently in them because the rate of decline can be as high as 10 times. Second thing is there are many risk prediction scores which can calculate how fast the child can progress to end-stage kidney disease, and most of them usually use some of the routine demographic parameters. Most importantly here is the glomerular versus non-glomerular. Glomerular disease progress fast compared to non-glomerular disease, and we have calculators for that. And the reason why we need to use this is when do we transit these kids to a nephrology care or a multi-speciality care. It is based on the predictive scores. We do know that albuminuria can not just have a cardiovascular outcomes, poor cardiovascular outcomes, but they can also rapidly progress. A study from the Indian, especially from the APNEICON group, said that kids who have more than 2 gram per gram proteinuria have a 3-fold risk of progressing to end-stage kidney disease. So how do we delay? This is where the management issues come. So make sure that the lifestyle modifications, that make sure that kids who are kids have at least 60 minutes of daily physical activity, and someone who is below 5 years of age, then make sure that they have at least 180 minutes of physical activity. Do not restrain them. Do not say them, oh, you don't. Do not restrain them in a chair or a toy. Make them play around, and at least this helps to maintain their growth hormone too. Being physically active helps to increase the growth hormone also. Do not restrict their protein intake. We all know that, especially energy intake is similar to that normal kids. In fact, they need a higher protein compared to the age match control, especially in CKD stage 3 it is 100 to 140 times. In CKD 4 and 5 it is at least equal to that of a normal kid. Malnutrition is the principal driver for poor growth. We can go with oral feeding as well as gastrostomy. Sodium intakes are age-based, and there are clear-cut guidelines in KDIGO what should be the sodium intakes. Make sure the blood pressure, we use a 24-hour ambulatory blood pressure management, especially at least once in a year, because that is what is recommended after the ESCAPE trial. Office readings are okay for 3-monthly monitoring, but once in a year go for ABPMs. There are both modifiable and non-modifiable risk factors. children, I mean, most importantly is the incidence of AKI. We need to reduce the incidence of AKI in pediatric kidney disease, chronic kidney disease patients to reduce the rate of progression. A healthy child is a healthy adult, so we know that if you do not manage these kids at a very young age, they are going to have a problematic adult. So we have all the parameters on the left side which we need to manage to make a healthy adult. I'm not going to talk about the routine management, just a line about erythropoietin. We need to have a higher dose of erythropoietin, mainly because erythropoietin receptors are on non-hematopoietic cells in children, so that's the reason we need a higher dose. There is dietary reference for calcium and phosphate, and monitoring is not much changed over the years. So just to summarize, we have the primary care when we identify children with CACD, preterms or maternal history is there in antenatal scan. Secondary care talks about estimating GFR equations, managing hypertension, and also screening special populations, especially with genetic diseases. Tertiary care involves preparing them for a kidney transplant and transition clinics. I've not talked about some of these things. There is a very clear-cut guideline how do we transition program to adult care. To conclude, children have different etiologies, disease projection strategies, and unique issues. So we need to use consistently the enzymatic method, especially because in neonatal period, GFR less than 90 is a flag sign, red flag, and encourage children to have the physical activity. And do not restrict the protein intake, follow the age-based recommendation, and 24 ambulatory blood pressure at least once a year should be used, and office recordings once in 3 months. Prepare adolescents and their families to transfer to adult-oriented clinical care setting starting from the age of 14 years itself. You prepare them, you don't transfer, you prepare them by 14 years and you can transfer at 17 or 18. This is the complete guidelines what KDIGO came with. Thank you.
We appreciate your excellent delivery, Dr. Pearson. I think Dr. Gopal can join us here so that we can take a few questions. Dr. Gopal, sure.
Can I start? So excellent presentation. So my question is should we do a urine albumin creatinine ratio or a protein creatinine ratio? Like this is something which is often asked in pediatric practice.
More practical is to do the urine protein creatinine ratio. But if the urine protein creatinine ratio is positive, then you can go for a urine albumin creatinine ratio to make sure that the proteinuria, you characterize the proteinuria. Because in kids, you have more of tubular proteinuria as well as glomerular proteinuria. So you need to make sure that what you are dealing with, once you have a positive UPCR, then you can do a UACR just to make sure that it is glomerular proteinuria and it is albuminuria.
And you classify it after you get the albuminuria, or you just classify it based on the GFR? Like the classify of the CKD staging KDIGO. So if you don't have the albuminuria, then you are not been able to classify as per that.
Yes, the heat map doesn't go with it. It has both G and A scoring in that. So whenever you're classifying, I mean, he can be a G1A3, G1A2. And we have shown that, even an Indian study has shown that albuminuria can worsen the decline of kidney function, especially if it is more than 2 grams. So that is the reason we need to do both G and A to actually prognosticate the child and manage.
So any comment by Professor, like what is your practice like? Do you do both albuminuria and proteinuria or just proteinuria?
Proteinuria first, as you rightly said, and then we also look at the albuminuria because it's been done in our labs, and we classify both G and A.
But we are not, I think we are not routinely doing.
But broadly, if you're doing proteinuria is fine if you don't have the facility to do albuminuria.
We have the facilities, but not like after family says better.
But if you can, it is better to do. But predominantly, you will find those who have proteinuria will be albuminuria, And tubular ones will only be seen in tubular disorders, predominantly like hand disease, etc. They will have tubular protein.
And I don't think there's been any studies done on it in pediatric, like with the proteinuria per se, like CKD staging as per the proteinuria.
No.
Sir, if the PCR is high, protein creatinine is 0, and the ACR is 0, A1, so are we going to change our treatment of enarapil or something?
What we
PCR is high,
yes,
and ACR is 0, sir.
correct. What we know is that we are dealing with more of a tubular proteinuria, and we can go on to the etiology, finding the etiology.
Yes, suppose no CACU.
Yeah, there is no
CKD
CACU. I mean, ACRBs is in general as renoprotective, whether it is proteinuria there or not, whether it is albuminuria or proteinuria, you would still use ACRBs, especially to maintain a blood pressure below 150 at some time.
Not for blood pressure. If the blood pressure is also normal, still we give, or ACR is high, we give enarapil. If the condition that PCR is high and ACR is normal, for a CACU, we now stage 2 something, we are going to treat with ASR. So this ASR, this PCR report, then nothing helping us in treatment, not helping us with the heat map. So why to send PCR? ACR alone is enough then?
ACR is more expensive, not easily available.
Sir, both are same price. For a lab, both are 600 for PCR and ACR.
Okay. So in our center, PCR is much cheaper.
The escape trial, we just look at the albuminuria or the
proteinuria.
The escape trials looked at the proteinuria, and it did show that reducing protein is good for the kidney. So even if the PCR is high, I will treat it with NLF.
So we did a small study in AIMS, and we looked at proteinuria both kinds, albuminuria and total proteinuria, and we tried ACE inhibitors. So there were about a small number of patients of tubular proteinuria. ACE inhibitors do not reduce tubular proteinuria at all. We showed that, and the rest of the proteinuria can be reduced.
That is one of the reasons why I said we don't use it. And the other reason we don't use in tubular proteinuria is because incidence of AKs are so common in our population, especially the acute gastroenteritis and all. The GFR declines very faster, especially when these patients are on ACE inhibitors ARBs. The incidence of recurrent AKs in a background of a CKD. So that is one of the reasons in tubular proteinuria we try to avoid ACRBs.
So I think we can take away the message that if you are having a proteinuria, and if it is a tubulopathy, then you know that you should be knowing it. And tubulopathy progressing into advanced CKD is relatively rare. So in a tubulopathy, you don't use ACE inhibitors. But if it is a non-tubulopathy but proteinuria, then you should be using ACE inhibitors.
Yes. In albuminuria, it is a general dictum to use.
Even without albuminuria, because we pediatricians normally we are not doing that much of urinary albumin creatine ratios.
So if you find that the proteinuria is high in a tubulopathy, then you should try and characterize the albuminuria, how much is the albumin. And if the albuminuria is high, then you can use ACE inhibitor, because FSGS also have in tubulopathy.
Like this.
With the advent of Webinar 20, whether this recommendation of conjugate 13 followed by 23 is changed or it remains the same?
So the company fellow says that your single shot of 20 is enough.
So we can shift to single dose of Webinar 20. So very important points both the speakers have brought in, that is transition to the adult nephrologist and the very rapid progression during the pivotal growth. This we have to recognize because he has already said that almost 10 times rapid progression of fall in GFR. So I think two most important points they have discussed is. Any other question from the floor? Dr. Raja.
What is the antihypertensive choice? Generally, you say ACARBs. Is it based on evidence in children or is it adaptation from adults?
Pathophysiology, it works. I mean, you have a pathophysiology how ACARBs works, and it is in general, but the same implies in pediatric population also. Yes. We only try to avoid beta blockers as it goes lower down compared to the adults. That's one of the changes. Or else it's the ACRBs, diuretics, the CCBs, it's the same.
A large scale trial did show that there is use ramipril 6 milligram per meter square, and there is an evidence there. Yes. Although it didn't compare against placebo, but then it was strict blood pressure control versus standard. Yeah. So there is evidence in that form, right? That you can use ramipril. That's why we shifted now to ramipril. And although younger children, we use an alarm.
Dr. Prakash, at what point in the management of pediatric CKD you are using growth hormones?
There is clear-cut guidelines on the use of growth hormones. I didn't come here because I didn't comment on that because this was more of an update. I didn't comment. One is you see the growth trajectories, you follow them at least for over a period of 1 year and see if they are falling below the standard deviations. You need to make sure that PTH is within twice the normal. Metabolic acidosis is corrected. Protein malnutrition has been addressed. You do an X-ray and there is no fusion of the epiphysis. So once they fulfill all these criteria, yes sir, Patna exam. And once they fulfill all these criteria, and since the prices have come down very significantly now, definitely we should start on them on growth hormones.
Use of growth hormone has led to deterioration of the kidney function.
No, I mean that is only because of the somatic growth. If you feel that what the explanation I gave in the puberty this thing, sir, it's the somatal. The decline is mainly because the somatic growth cannot, and the nephron lags behind the somatic growth, and that shows a decline. But as such, growth hormone per se, even in transplant population, we see that growth hormone does not cause any decline in function.
Dr. Amit, you can have some comment on use of growth hormones.
Yes, sir. Definitely we should use growth hormones and yes, sir. I think I'm on Yes, sir. And as also told that we have many patients with CKD and we are planning to use growth hormone, and we all having told that we know that growth hormone is something which is actually beneficial and we should use it. Yeah. Yes.
I have just one comment. Just one comment about growth hormone, that make sure that your nutrition is optimized, your acidosis is optimized, your CKD MPD is optimized. Because there are general nephrologists and the pediatricians also in the audience, so we should not give that message. Because I am from Dr. Leslie's school from Patna Street Hospital, and she strongly believed, and she has shown in studies also, that if the nutrition is optimized, most of the time we may not even need growth hormone. And there are studies which have compared the USA standard with the UK standard and the European standard. USA uses lots of growth hormone, maybe quote unquote driven by pharmaceutical industry, and their growth is not as good as the UK and the European growth. Sorry, I will not be sponsored by
I take a liberty by asking one important question. We have here a stalwart athletic nephrologist. Suppose a child having CKD achieved 100, whose baby is this now? The adult nephrologist will deal with this, or the pediatric nephrologist? This is a legal question. As an administrator.
That is the reason, sir. There is a clear-cut transitional care how we transfer the child. I mean, this starts very early from 12 to 14 years of age. There is a plan in place, starting from etiology, everything explained in, and what are the issues that has already been addressed by the pediatric nephrologist. And he would then, in fact, the family visits the adult nephrologist for a couple of times. If they are satisfied with the care of the adult nephrologist, then they come and say that yes, we are okay now, confident to move to the adult nephrologist. So it is over a period of 3 to 4 years that the transition happens. And now if the child has moved to an adult and if she's been nicely transitioned, I think it's the care of the adult nephrologist henceforth.
Yeah, just to add, sometimes it happens that the child is brought and is at the brink of turning 18 plus, and then it becomes a dilemma because the moment while you are preparing him for transplant, and he's crossed the age of 18 years, then we prefer not to do a transplant in the pediatrics. We consult the adult nephrologist, take them into confidence. We see to it that the child moves smoothly to the adult bed consent and then it's transplanted there. We provide all support in terms of investigation, etc. And make sure that the transplant is done. But that happens very uncommonly. You rightly said that we begin the transition early, but very often they are not interested in going even after 18 plus because they are so used to pediatric nephrologists. So that is another issue, and they continue to follow with us while seeing the adult nephrologist till the age of maybe 20-25 years. But the primary physician there is an adult nephrologist. But they keep coming to us, showing the report that we have more confidence in you because you treated me all my child over the years.
So big round of applause to both the speakers. And with this, we close this session. Thank you, Yes, Dr. Gopal.
So just an anecdote in this, about this transition care. There was a kid in Sydney, she was born as a girl and she was transiting into an adult care and then she started identifying as a boy. So my professor at that time said, in the EGFR equation, what will you put as? She was born as a girl, but now the child is identifying himself as a boy. So what is the sex you are going to put? So these are some of the things which can crop up.
Thank you, Dr. Larson. I will request both the speaker, Dr. and all the chairperson to please come to the to receive the memento. Moving on, we have the next session. I request Dr. Pankaj, speaker, and for chairing that session, we have Dr. Jayant Prakash sir, Dr. Shashi Kumar sir, and Dr. Amit Kumar sir. Dr. Jayant Prakash sir, currently HOD Department of Pediatrics, IGMS, a very famous pediatrician. Dr. Shashi sir, Director and HOD, Dean of Sciences, Bharat Satyanarayana Hospital, and Dr. Amit Kumar, Associate Professor Pediatrics, IGMS, and Pediatric Endocrinologist. I request all the three chairpersons to please come on the dais, and the speakers of the Pankaj Hari sir.
Good evening, everyone. It's my honor to introduce Professor Dr. Pankaj Hari sir, my teacher. Sir, being student protection, sir is one of the biggest names in pediatric nephrology worldwide. I'm not reading this. Sir is HOD Pediatrics 8, really, and sir has many papers. That's all. On personal note,
सर आप भी देखिए सर आप भी आइए सभी लोग यस यस यस
and many of you might not know that sir is a great spokesperson and a very good guidance there. So over to you.
Thank you so much. You've been a very kind introduction to me, and I'm overwhelmed actually. I'm coming to Patna after 20 years, almost. I was an assistant professor way back in 2002, and it's a great feeling to be amongst you and talking about dialysis and tomorrow. So I'll be discussing how to optimize dialysis, and the first question that comes to mind is, when should I begin dialysis? And the guideline would say less than 10 ml per minute is the time when dialysis should be considered. But this has been a debate whether early initiation versus late in adults, and the same has been true even in children. So this is the registry data from the European Society of Pediatric Nephrology and European Renal Association that looked at if you begin dialysis below 8 ml per minute versus above 8 ml per minute, there is really no difference in terms of death rate and the chances of getting transplantation done. There is no definite benefit in growth, anemia, hyperphosphatemia, except that hypertension is lower because of better fluid management if you begin dialysis early. Now, we had a lot of discussion on the EGFR and its unreliability, particularly gets heightened when the GFR is below 15. So most of these GFR formulae have been developed and they work very well between 50 to 75 ml per minute. But they tend to overestimate the true GFR when in a patient who is in CKD5, and therefore always look at referred. Just about 1/3 will ED, the rest are put on hemodialysis. There are various pros and cons. 10 kg child where hemodialysis sometimes can be doable. It's much gentler and sustained fluid removal is seen in peritoneal dialysis. And the families tend to burn out if particular method of PD. So if you're using an automated PD, a cycler, with the CKD, very often we rely in the form of interdialytic weight gain, presence of edema, hypertension. But a lot of children will have no edema and yet they have extra fluid in them. And to as much as in a 20 kg child, maybe 2 or 3 kgs extra without any edema visible. So hypertension, we always take as a guide. If the child is on multiple antihypertensive drugs, then it seems that removing fluid is a better option. But then again, there can be other reasons for hypertension as well. So there are other methods by which you can try and figure out whether the child is overhydrated or not, and one can use either biochemistry. One of the markers is in the IPPM registry, which I'll be discussing later, is the erythropoiesis stimulating agent resistant anemia. These children tend to be overhydrated. You can use ultrasound focus looking at the lung B lines, which is the presence of fluid within the interlobar septate, which can guide you that yes, the child needs to have more ultrafiltration. If the IVC diameter is increased, and looking at the collapsibility index. And one can also use bioimpedance spectroscopy. Now this is available and it uses electrical currents to differentiate how much is the fat mass, how much is the extracellular water, how much is the muscle mass. Yet it is not very well validated in children. And we tried using it and we were not able to demonstrate fluid overload well using this technique. So we routinely are not using it. Ways of optimizing hydration in a patient who is on dialysis, restrict dietary sodium, try and preserve residual function. So you could use RAS inhibitors for preserving the renal function, and use of diuretics. It increases salt and water excretion, and it's been shown to preserve residual renal function. And this was shown very well in the IPPM registry. I'll show you the curve there. Removing sodium-containing drugs, particularly if you are using potassium binder, then try and use a calcium-containing binder rather than sodium. In PD, you can modify the dwell time, the dwell volume, use an icodextrin exchange because that will help in a more ultrafiltration. In hemodialysis, again, you can try lowering the dialysate sodium, and also you can go for intensified hemodialysis to improve the ultrafiltration. So in peritoneal dialysis, optimizing ultrafiltration is that these smaller volumes, the low fill volumes and short dwell time, they improve ultrafiltration. The standard generally is about 1100 to 1400 ml per meter square in older children. So you can use a low fill volume and a short dwell time, and this will remove pure water. Solute clearance is lower here. Then you can use long duration dwells, which will help in removal of solute as well as middle molecules. So you can use a long dwell of icodextrin. If you're doing an automated PD in the daytime for a CAPD, you can use it as a night time. And it's been shown very clearly that if you increase the amount of glucose in percentage, then the ultrafiltration with each percent increase in dextrose results in about 250 ml extra ultrafiltration. But then we should also understand that it's not a very good strategy always to increase the dextrose because it is toxic to the peritoneum. About the solute clearance, you could look at the phosphate levels. You can use icodextrin because that will also improve the solute transfer. Use of KT by V urea in PD has not been shown to correlate very well with the survival or even the growth parameters in the children on peritoneal dialysis. You can target a KT by V of 1.7, which is combined, which means you use the dialysis KT by V, add to it the residual kidney function KT by V. And again, this is just a number. If your patient is doing very well and if the KT by V is even lower, there is no need to increase the PD prescription if the other parameters are satisfactory. Now, what is the role of peritoneal equilibration test in children who are on peritoneal dialysis? Generally, we prefer to do it once at the beginning, and also if the child has had a peritonitis because the peritoneal membrane characteristics might change. So it helps us identify patients who are at loss of ultrafiltration failure. One can use either a 2.5 or 4.5% dextrose and after training the overnight well, look at the dialysate creatinine glucose concentration at 0, 2 and 4 hours, and again also look at the dialysate and plasma creatinine ratios, and also the decline in glucose levels at 0, 2 and 4 hours. So the standard PET is a 4-hour test, but you can use a mini PET which is 2-hour test and which is easier done and is almost as good as the standard 4-hour PET. Now there is something called an FX time where the two curves cross, which means that this is the time which shows you that this is the maximum ultrafiltration achieved here, and beyond that it is mostly the solute clearance. So when you are using guiding ultrafiltration, you could use the time based on the FX time, and so from here in this curve it appears that about 40 minutes is a good FX time, and using this you could optimize the ultrafiltration. The longer dwells will help you in solute removal. However, there are criticism of the PET test also. It can be time consuming, error prone. There is a concept of adapted PD for fluid overload in patients who are dialyzed, and this is the concept given by Fishback. Way back in 2013, he said you combine short dwells with the longer dwells. Now it's something interesting that you do two small dwells, small volume dwells which are short in duration, just about the time of the FX time, and 50% of the large dwells, and then followed by 3 large dwell PD, which is double the initial short dwells, and the duration is also increased. The longer dwells and the larger fill volumes would improve the solute clearance. The shorter ones promote the ultrafiltration. I was talking about the IPPN registry. This is the International Pediatric Peritoneal Dialysis Network Registry. Initially it was called as, later now it's been called as IPDN, which includes both Peritoneal Dialysis Network as well as the Hemodialysis Network. And there are about 3,700 patients in the Peritoneal Dialysis Network. So what they figured out, the paper that was published in 21, which looked at the data collected in all these years, showed that overweight and obesity was a problem of the West, 30 to 40% in Middle East. Malnutrition and protein energy wasting was more common in Southeast Asia. They were able to show that height was inversely correlated with the ECH. Blood pressure and volume status were the determinants of left ventricular hypertrophy. And what they interestingly showed that when you use diuretics or when you do not use diuretics, there is better residual function with the use of diuretics. So that's why they recommend that it's better to use diuretic along with it, so your patient doesn't develop oligoanuria. Now in hemodialysis, the optimal access is fistula first, as in adults. This is again the same policy has to be adapted in children. However, there could be a problem when the child is lesser than 20 kgs, if the vessel size is small, there is a lack of expertise for making fistula in a very young child, or if an early transplant is planned, let's say within 3 months you're planning a transplant. It avoids morbidity due to the central catheters, which frequently develop catheter malfunction and infection. In hemodialysis, the ultrafiltration can be optimized by decreasing dialysate sodium. It helps in better lower interdialytic weight gain, better blood pressures, or you can alternatively use intensified HD, which means add a nocturnal HD or daily hemodialysis. A target KT by V of single full KT by V of 1.2 to 1.4 is sufficient, and for the intensified hemodialysis, it can be 2. Now, what is hemodiafiltration and do children benefit from hemodiafiltration? It is a therapy that combines diffusive and convective solute removal of at least 20% of the blood volume processed through a high flux dialyzer. What you need is a good machine which has an accurate UF control, and it is in a 5008 you can do it. High flux dialyzer with a UF coefficient of more than 20 ml per hour. And you need ultra pure water for this, and therefore, because if you are generating the replacement fluid to the dialysis machine, then the water should have less than 0.1 per unit per ml, endotoxin less than 0.03 units per ml. Otherwise, you should not be using it. So typically, pre-dilution would have lower clearances, and therefore post-dilution is preferred, except when there is a high risk of clotting. The optimal convective volume is been shown to be 20 liters per session in adults, and it's been extrapolated in children to be 13 to 15 liters per meter square. A filtration fraction should be at both 30 to 35%, which is the blood flow rate of 5 to 8 ml per kg. Gradually, you can deeply increase the blood flow rates. Now, it's been shown to be beneficial even in children. The reason is that it results in better clearance of toxins, increased removal of cytokines, improved hemodynamic stability, less intradialytic hypotension, faster dialysis recovery. So the adult trial which pooled data from 4 RCTs were able to show reduction in all-cause mortality and cardiovascular mortality. In pediatrics, we do not have a randomized controlled trial, but there is a comparative trial of hemodiafiltration versus hemodialysis, which showed that there was lower annualized carotid edema media thickness, Z-score increase in hemodiafiltration. Height SDS was better in hemodiafiltration. There was lower interdialytic weight gain, better blood pressures, lower beta-2 microglobulin levels, improved growth, school attendance, activity, and less cramps. So to summarize, when we have to choose a dialysis modality, we must consider the patient size, accessibility, patient's choice. Optimization of hydration is key for preventing cardiovascular or improving the cardiovascular outcomes. Blood volume and PD and the dwell time in peritoneal dialysis can be adapted for better ultrafiltration. For hemodialysis, AV fistula should be the access of choice, but provided if the child size permits. Target KT by V should be 1.2 to 1.4 interventional hemodialysis, and hemodiafiltration is associated with better fluid control and outcomes, and therefore it can be offered to children who are on prolonged dialysis vintage, maybe 6 months or more, wherever there is a facility available. I'll stop here. Thank you very much for your patience.
Thank you, sir. It was an excellent talk, and as we were in the previous session, I'll ask sir if you could join us here, so that the question and answer session can be done jointly after the next talk, which is by none other than Professor O.P. Mishra. I feel very odd that I am calling my teacher to the dais and I am sitting, so please permit me to stand and serve. Here is a strapping young man of nearly 70, and he has always been teaching. So welcome, sir. And sir will be speaking on dialysis, peritoneal dialysis, And he's been teaching all along. When I was an MBBS student at time in speech, he was teaching. When I was doing post-graduation, he was teaching. When I was doing senior residency, he had come back after fellowship with Kumud Mehta man. And I was his poking man, कि जैसे यहाँ PD डालो, वो so under his guidance I poked a lot of kids. And you know, and he still is teaching. So over to you, sir. And sir का achievement भी बता ही देते हैं. I can be naughty, you know, with him. So I never knew that sir was former president of ISPA 2019 to 2021. So this is a big news. And at present, sir is professor and head at pediatrics, Heritage Institute of Medical Science, Varanasi. Sir had been to Germany and we have seen the photographs, both Germany के photographs है. Sir told me कि मैं जहाँ काम किया वहाँ NPM regime develop हुआ. पता नहीं सच है कि झूठ, मैं नहीं जानता. So please, sir.
Okay, thank you, Dr. Jain, for nice words, and I would just express my sincere thanks to Professor Prasad and his team who invited me here. Some of the lecture content Sir has Dr. Pankaj Sir has already covered. PD is the main modality of dialytic treatment in younger children less than 20 kg in this CKD. Its physiology, indications, types of catheter, prescription, fact Sir has already emphasized. Complications are very much important and certain key messages. We all know the CKD is defined by decrease in eGFR of less than 60 ml per minute per 1.73 meter square lasting for at least 3 months or structural kidney function. Well, range is quite wide, 15 to 74.7 prevalence. Caicot is the most common cause of CKD as well as CKD grade 5D also. And in children below 5 years, CKD is the main, and after 5 years, it is the glomerulonephritis. If you see the peritoneal membrane, it is a semi-permeable in nature. Mainly, movement of the water and smaller molecule is through diffusion from higher concentration to lower. And when convection includes larger molecule movement under the influence of hydrostatic or osmotic pressure. There are 3 types of pores in the peritoneal membrane. 95% is small size, allows water under diffusion, smaller molecular weights, and 50% of the ultrafiltrate. Glucose is also moves through that, and 50% of the ultrafiltrate remaining is through aquaporin channels, 2 to 4%, with small pores. Larger pores are very 1 to 3% in the peritoneal membrane, and it is by the convective method. Here this case of a young infant who had dysplasia presented with biochemical alterations suggestive of CKD. Besides management plan of medical management, control of hypertension, anemia, and metabolic disturbances, then we have to provide the dialytic support. In the child is young, so PD is the main option, mainly in the developing country. So biochemical and clinical characteristics with the aim to commence KRT early enough to prevent especially malnutrition and learning symptoms. Ideally, we should start thinking to provide, nowadays it is kidney support therapy, less than 15 ml per minute per 1.73 meter square with symptoms and signs of uremia, fluid or malnutrition. But Professor has already told, most of the literature says it is the cutoff 8. Below 8, one should think to provide even in asymptomatic CKD patient also. PD is the very feasible option, effective in low resource setting, more compatible with childish schooling, social life, and can be done at home with the APD machine or even manual exchanges in the properly trained caregiver is there. Regarding the availability of catheter, it is available. This is the lower one is the ISPD recommendation, and 31 size is for below 6 months and 41 is for pediatric or adolescent. Ideally, the double cups on neck and coil catheter put by the laparoscopic surgeon inside the peritoneal cavity. The first cup is under the rectus abdominis, the second one is the superficial area, and then a tunnel and skin site is there. After putting the catheter, it should be 10 ml exchange per kg of dialysate with heparinate until the fluid is clear. X-ray abdomen is recommended to check the position of the catheter, and we should wait for minimum of about 2 weeks. But sometimes it is late from next day onwards, so I will tell you what will always be done. Fluid cell count and culture is done weekly to detect early infection with each flush. At initiation of PD with adequate wound, about 2 to 3 weeks, or if immediate PD is required, then day 1, 3 and 5. Topical antibiotics, mainly mupirocin, is applied at the active site to prevent the infection. There are 2 forms. One is manual, that is CAPD, automated devices like CCPD, tidal PD and night PD. An APD machine has its all connections supplied by the, now in our country also available, but the cost factor is a major limiting thing. If you look at the type of setting, the continuous and ambulatory peritoneal dialysis, 3 to 5 exchanges in the daytime, each take by about 4 hours, and a long 12. And then tidal PD, daytime is dry, night time is maybe every 6 to 8 cycles, and every third one is complete drainage is done, and then 60% of the amount is left over in the peritoneal cavity to provide some clearance. CCPD is almost like CAPD, but a longer 12 and shorter night time, and a night PD just closer in the night. About 2 hours each exchange, 5 to 10 nocturnal exchanges are done, depending upon the test marker modified. And basic thing is we have to achieve the ultrafiltrate and solute clearance, which depends on the field volume, dwell time, dialysate compositions. Initially, we start with the lower field, 300 to 500 per meter square per exchange. In infant, little lower also. Body surface area is equated with the peritoneal surface area. That's why the fluid calculation is the per meter square. And gradually one can increase to 800 to 1000, up to 1100 to 1200. But in a fan, it should be restricted to 600 to 800 ml per meter square. In APD, initially lower, but one can reach up to 900 to 1200, yeah, maximum 1400 ml. But in below children, below 2 years, not more than 800. Dwell times determine the number of cycles and PD duration, and mainly solute transport status of peritoneal membrane, demonstrated by the PET results. If the immediately putting the catheter in the next day PD is initiated, so lower volume is in children and adolescents, and it's still lower in infants. And day 1 to 3 like 300 ml, then next 3 days 500, then 800, and gradually by week 2 we achieve the target 1000 to 1100 ml per meter square exchange. Lactate based and bicarbonate based, 2 types of them. Lactate is mainly lactate, but pH is acidic. Sometimes when there is abdominal pain, discomfort, so people prefer bicarbonate based with neutral pH of 7. Otherwise composition is almost the same. What should be the PD fluid characteristics? That lowest glucose concentration should be used because it is toxic. Glucose oxidation product is there. So correction of metabolic acidosis is better with bicarbonate based solution. Low calcium containing fluid, there is risk of hypercalcemia. Ipodextrin may be in one long well if the insufficient ultrafiltration is there, otherwise not. PD should be done at 1 month after, ideally recommended 4 weeks after initiation of the PD. That after 3 to 8 hour exchange in the night, next day when the child visits in the PD room, complete drainage is done, white types collection is done, and 2.5% glucose solution containing PD fluid is infused, 1100 ml per meter square, and there are 2 types, Professor Pankaj sir has already emphasized, short 2 hour PET or 4 hour PET, we calculate the ratio of D by P or D by P0 glucose concentration, and it is plotted against the standards where there are 4 types of high average, low average, low, and this one high. Depends, but normally 4 hour D by P is enough to know the PET result and modify the prescription accordingly. If the patient corresponds to the high transporters, that is any D by P ratio and D by D0. D by P more than plus 1 standard deviation from the mean, or D by D0 less than -1 ST from the mean, it means ultrafiltrate is less. So such patients are more suited for short duration well time. Because with short duration wells, we can improve on the ultrafiltrate by like NIPD. Just reverse, low transporters, low solute clearance, and good ultrafiltration benefited by longer high volume wells. And otherwise, high average transporter and low average, they are treated with the standard CCTV like this. Fortunately, high average constitutes about 53% out of the total, and low average. And if you combine, it is 84%. So majority of the population is having, with the standard PD setting, we can achieve the good ultrafiltrate and good solute clearance also. The LC's adequacy, sir has already told that it should be more than 1.7, that is 1.8 and above, and it is both renal clearance as residual renal clearance as well as peritoneal, and it is combination of the above, and it is calculated with the urea that constitutes the 60% of the body weight. So D by P urea or urea and urine upon plasma urea is taken and 24 hour dialysis, and it is calculated on the weekly basis, so it is multiplied by 7. We all know that we have put an foreign body inside the peritoneum, so complications are always expected when there is pain, swelling, redness, and ISPD has given the scoring system rated 0, 1 and 2, and the score, exit side score is 4 and above. It is presumed that infection is there, and if it is 2 or above and with positive pathogen culture, it is definite. Our presence of purulent discharge alone is sufficient for the presence of infection. Prevention of exit site and tunnel infection is very important, that one should take care of, like regular cleaning the application of the mucosin at the exit site, or cleaning with the antiseptic solution, hand washing. Our oral antibiotic like cephalosporin or ciprofloxacin as empirical treatment pending culture report. Tunnel infections are treated either oral or IV or intraperitoneal antibiotics as recommended by the ISPD. Infection with gram-negative organism like Pseudomonas aeruginosa is difficult to treat and often resulted catheter removal. It is refractory to it, may be refractory to treatment. So a simple guideline approach is that cloudy peritoneal effluent, if the cell count is more than 100, more than 50% of the cells are polymers, culture is positive. Pending the report, you start empirical therapy, maybe certifying monotherapy intraperitoneal. If it is not available, then gram-positive coverage either by first generation cefazolin or vancomycin. And if it is suspect gram-negative, then ceftazidime or aminoglycoside IV installation is there. This is the detailed algorithm recommended by ISPD 22, that after evaluation, again same thing, if the gram-positive coverage we require, first generation cefazolin or glycopeptide antibiotic vancomycin. If it is gram-negative coverage, third generation cephalosporin or aminoglycoside, and monotherapy I will say certifying. And then you look for adjuvant, pain control, heparin installation, antifungal prophylaxis with fluconazole. And if the child is not responding, fever, septic presentation is there, significant pain, are unable to perform PD at home, then admission and treatment of peritonitis. This is available in the ISPD guideline 22. How do we give intermittent? If we give intermittent intraperitoneal, it has to be for 6 hours long dose, so that adequate efficacy is there. Otherwise, in continuous loading dose followed by maintenance. LD is loading dose, MD is maintenance dose. You need not to remember, we have to see the chart and modify the prescription accordingly. A long list of antibiotics and antifungal are given. Nerve cell staphylococcus methicillin resistant if the organism is growth, either clindamycin or vancomycin or teicoplanin, 3 weeks treatment. If it is sensitive, then cefazolin or cefepime. Coagulase counts, cefazolin or cefepime, 2 weeks. Enterococcus, ampicillin or vancomycin. Total duration length of therapy is 2 to 3 weeks. It depends upon the type of organism, gram positive, gram negative, and then treatment accordingly. Same thing. Other complications besides peritonitis and pericatheter leak or leak less than 30 days, leak more than 30 days, PG catheter outflow, hydrothorax, 50 to 60% cases on the right side, hernia, hemoglobinuria, intestinal perforation. Encapsulating peritonitis is severe form of adhesions of the thickened peritoneum with the bowel presenting as intestinal obstruction, late complications. So to summarize, it is a dialytic modality opted by organizational setup of the center, socioeconomic condition of the caregiver which the person can afford. It remains the main dialytic modality of treatment of CKD in infants and young children in developing world. APD machine is preferred. One can identify various modes depending upon the affordability and compliance. Trained dialysis staff and training are given required for success of the PD. First, we have to admit, we have to train the caregivers. Our staff should be trained. Our dialysis technician or resident staff, and then it can be time to time compliance has to be checked. Early identification or treatment of infectious complications are essential to prevent the catheter loss, and preventive measures by the caregivers are also needed to avoid of the infections and frequent hospitalization. So thank you very much.
Thank you, sir, for your detailed elaboration on the peritoneal dialysis in pediatric population. And I must appreciate and must thank the two stalwarts of pediatric nephrology, Dr. Pankaj Hari and Professor Mishra, for giving a detailed explanation regarding the management of end-stage kidney disease in pediatric population. Because many a times it's like a nightmare for us. In the mid of night, we get a call from emergency that 10 kg boy or 15 kg boy came with a bicarb of 10, pH of 7.0 or something like that, and patient needs dialysis. So the first thing came to our mind: how can I manage the catheter, from where I can get, and who will put the catheter, whether it's a peritoneal catheter or hemodialysis catheter. So these are the two major challenges for us. But thank you both of the legend speakers who makes this complex topic very lucid. Now this platform is open for any comments or questions from the audience.
So thank you again for the nice presentation. I'd like to know, like in your practice, what is the antibiotic that you are using as initially for intraperitoneal antibiotic for peritonitis? Because if I remember correctly, ISPD is saying cefepime. So are you using cefepime? As is the first one?
No, we use as per ISPD recommendation.
Pankaj sir? Because we used it initially and we found it, we didn't have a good response.
So we are not using cefepime as the first line as of now. We use a combination very often because cultures are not very often positive. So cetrazidime, cefazolin combination, we also use.
Yeah, we were like as soon as the guideline came, then we started using cefepime and we were not getting good response. So we also went to that combination way. And I was speaking with other doctors, like many people here will be knowing Professor Arup Datta and Dr. Arup Datta, and he was also saying that like in India maybe cefepime may not be a good option.
It may be, but if the culture is positive, we can change. But
but most like initially no, and also like we are not getting the culture for at least that is some time.
So, most often in India we get a culture negative peritonitis. So, has the newer culture techniques, like the mannitop mass spectrometer, has changed, has increased the incidence of culture positive cases? That is one question. And second thing is, do you start antifungals right away or along with antibiotics, or what is the, just local prophylaxis with oral statin is not available. So what is your line of management?
Routinely we do not start antifungal prophylaxis. We do not, but culture strategy is same in entire country. It has not changed.
I know the guidelines say that we should actually, and we often are not starting, but I think we are taking some very proactively starting to absorb along.
We are giving the mouth
oral,
the antifungal. But any evidence on pickup, so that might be interesting.
There's no difference.
Doctor, I do prophylactically laparoscopic surgery in 60 minutes before one dose of.
Yeah, that we are always giving. That we are always giving. That is for the pick-up planning. Like but he was asking about the antifungal.
No.
And as per the guideline,
but guidelines say
yeah, usually.
Sir, our culture rates are very bad, like 20% irrespective of what you do, because many patients actually take antibiotics before actually they converse. That is, that would be one. Regarding antifungal we were using, so then we found, there is increase in incidence of fungal peritonitis, which are actually resistant to fluconazole. We have candida which is resistant to fluconazole. So I don't know how useful that is.
Not only in this condition, even in neonates with fungal sepsis, fluconazole is not active. We have to go with the amphotericin B or capsofungal. So, but as everybody is telling that we are not using fluconazole, so it's very good thing also. It is resistant. And you are right, by the time the patient reaches to us even in the regular follow-up, he has received some. Like nowadays, traditionally, I'm not criticizing, but our colleagues, they have given meropenem and this one vancomycin already outside. That is the main problem, they want to do. And the child has come with the septicemia, peritonitis, and infection.
So if you want to ask? So you need aluminum toxicity screening for the child undergoing frequent dialysis. Because aluminum toxicity affecting the neurodevelopmental outcome is very much affecting the children. So you need routine aluminum screening for the child undergoing frequent dialysis.
I think before this, when we are not using RO water, at that time aluminum toxicity was a problem. But nowadays, since we are using RO water, so I don't think it's much a problem. So if
dialysis fluid is aluminum free.
Yeah,
totally aluminum free. Yeah. My next question is, because can we rely on urinary albumin creatinine plus clinical symptoms for peritoneal dialysis instead of EGFR? Because serum creatinine is very unreliable for the children depending upon the muscle mass. So why not rely on the urinary albumin plus clinical symptoms instead of GFR?
Recommendation of to initiate the kidney support therapy, the pharmacokinetics, the PhD, whatever it may be, it is based on the EGFR. Ideally, sir, when the EGFR falls below 15, we should start thinking. And when it goes to less than 10, which now the counseling of the parents is started, not only to start, but maybe preemptive transplantation also. And 8, level of less than 8 has been even in guidelines saying asymptomatic. Otherwise, one day in the night he will come with multiple complications and the child may die in the night by the time we start the dialysis. And we have seen
Exactly, I think when we talk about we generally would find that the true GFR is actually much lower. So therefore, in such a situation, I think it's better to initiate dialysis, because in our country we are actually starting it late.
Due to paucity of time, just last question.
Sir, I have a question.
So recently we have started CAPD program at our institute. So what I have observed in initial few patients, when after stabilization we put them on long night dosing as well. And after a month or so, we didn't find any considerable, fall in urea and creatinine. So later on, and the acidosis also persisting, although we are giving all supportive medication, including bicarbonate. So later on, we switched to twice, daily short dose, and 4 to 6 hours in the daytime and 4 to 6 hours in the night time. And thereafter, what I observed that the urea and creatinine was slightly better as compared to the long dose that I was initially doing it. So sir, my question is, the child presents a very high urea and creatinine at the first go. Then should we start with these 2 short burst sessions and later on should switch them to longer? Or I mean, is there any evidence or something like that head-to-head between one single night well versus 2 short bursts in countering these type of situations?
Also make sure that the dwell volume is adequate, because dwell volumes are not adequate for longer.
So we started this as a weekend to one
gradually escalated. Yeah, you can modify, as I showed you, the adapted PD, wherein you, depending on the need for ultrafiltration, sometimes the patient comes in with very severely elevated, then you can have short cycles, predominantly focusing on ultrafiltration, and then later on then focusing on the soil disposal. So long wells generally, and very long wells are when you're using, we must better use the active extent, because then
actually that's the cost factor, sir. Mostly we are very poor and we are on annual PDs. So
yeah, even if you've tried splitting it into a 6-hour wells, it's working, it's fine.
Thank you, sir.
So we close the session. Thank you both the speakers for their excellent presentation.
Thank you, sir. Thank you both the speakers and all the chairpersons. I request the speakers and chairperson to please come to the photo booth for the mental presentation. We have seen that pediatric CKD, we have seen dialysis, and moving towards the next part, I will invite Dr. Rajiv to please come on the dais, and for chairing the session we have Dr. Anuradha Singh Ma'am, Associate Professor Pediatrics Department PMCH and in charge of thalassemia and hemophilia unit. Gupta, Additional Professor in the Institute of Medical Science and also in charge of Pediatric Nephrology, and Dr. Jamshid Anwar, Assistant Professor Nephrology, Narendra Metropolitan Hospital, Patna, and Consultant, Paras APNEICON. Please come on the dais and Raju sir.
So, it's pleasure to Rajiv Kumar sir, who is working in pediatric nephrology. Doesn't need any introduction. He is a much popular figure in pediatric nephrology. Kolkata, and is member of all the society related to pediatric nephrology. And the most important sir is linked to Patna. That is very recent behind. So over to you, sir.
Thank you very much, and it is always nice to be back to the roots. So I'd like to start with thanking Pharmacist Professor Raman Kumar and Professor Gopal Prasad for firstly agreeing to host the APNEICON, the Eastern chapter of the ISPN, and also I'd like to congratulate the whole team for putting up the show. So I'll start with the objective of the next 15-20 minutes talk is sort of discuss the challenges of pediatric kidney transplant, because if you are not preparing yourself properly, then you are actually preparing yourself to fail. And the major challenge, I'm sure all of you agree, is the lack of kidneys, but then there are lot of other things like lack of access to appropriate health care, social barrier, economic barrier, medical barrier, surgical barrier, policy barrier, knowledge barrier, and hopefully in the next 10-15 minutes we will be discussing some of these. But what is the most important requirement for kidney? So anyone from the house, what is the most important thing? Somebody already said, right? The availability of a kidney. And this is a picture drawn by one of our girl waiting for kidney on dialysis, and it's very simple. If someone is willing to donate a kidney and it matches, you can have the kidney. But it is not that simple, because we have to know about the donor. The study says that living is better than dead. The study says that 18 to 50 years is a good age to donate, and study says that despite all the advances that we have made in our immunosuppression, better matched kidney is a better outcome. But studies also says, and it is very important, that half a loaf is better than no loaf. Just like in proteinuria, partial remission is better than no remission. Similarly, in kidney transplantation and dialysis is not a good thing. I am sorry, I repeat it everywhere, dialysis is not a good thing. It can keep you alive, but it cannot keep you healthy and alive for a long time. Before we select a donor, we always remember our Hippocrates oath that first do no harm. So we are not only investigating the donor to be sure that the recipient will be good, we are also investigating the donor to be sure that the donor does not go into harm. But there is a lot of scarcity of kidney. So last year, as per the NOTO, there was about 11,000 plus transplant, and there is a scarcity of about 2 to 3 lakhs people are waiting for the kidney. And if we go to the disease, it was worse. We will come later. And we have to really percolate this message. This is from conclusion from the ERA EDTA group that living donations should be regarded as an acceptable procedure, and the long-term risks for the donor are generally low, and in many instances they are largely offset by the overall benefit, not only for the recipient but also for the donor. So this is something that we have to, as a doctor community, as a nephrologist community, and as a pediatric nephrology community, we have to make sure that it is percolated into the aam janta. Because what we get is like comments like kidney देंगे तो बच्चा नहीं होगा, kidney देंगे तो हम काम नहीं कर पाएंगे, and this is very common even among the parents. So how can we overcome the donor scarcity? Obviously we can improve our deceased donor rate because that is something one can try to achieve, and believe me, like I don't think there is any evidence that if you take your kidney upstairs to God, hell or heaven, it really makes any difference. But people still don't understand, and most of them do try to take their kidney upstairs to heaven or hell. So this is something that again needs lot of effort from the community, but also a lot of effort from the government. Which some parts of India, as you can see, is doing well, but our region in eastern India, despite a lot of effort from many of the stalwart nephrologists, is still lagging behind, and pediatric is still lagging further behind, because unlike many of the Western world, here children don't get any additional point. Although children are expected to live longer and contribute much better to economy, but unfortunately, because we are not vocal, we are not getting that. The other ways of overcoming donor scarcity includes APO incompatible, and very important, again we are lacking, is the paired donation. This is something that it can be worked out, is much better than even APO incompatible. Recipient workup in pediatric, we do almost the same thing, but we do a thrombophilia screen if we are dealing with very small babies or there is a history of thrombosis, and we make sure about all the vaccines. The other thing that we do is a proper Doppler of the recipient vessels, noting not only whether the thrombosis happening but also the sizes, so that the anastomoses the surgeons don't get any surprise. And obviously bladder assessment, because I think it was mentioned by previous speaker only that a significant percentage of end-stage kidney disease does happen from caput. So with that sort of a background, we will go through the 5 cases quickly and see how the challenges that were presented. This one presented to us at about 5 months old, had a creatinine of 3.9, was polyuric. Polyuric means 10 ml per kilo per hour. That was the urine that the child was making. And the underlying diagnosis later on came back as HNF1 beta. So creatinine 3.9, CKD stage 5. We were thinking of starting dialysis, but before that we thought that let us put in a gastrostomy tube. So we put in a gastrostomy tube and that worked. not only it helped in gaining the weight, just after gastrostomy you can see the zooming up of the weight, but it also decreased the creatinine and improved the GFR. Why? Because this child was most probably having a chronic hypovolemia, kidney was not liking that, and just making sure that we are catching up with the volume did make this difference. So we were able to postpone the dialysis, and I'm not sure how many of you have been associated with chronic peritoneal dialysis. In a 5-month-old, his weight was at that time was 3.5 kilo. It is a nightmare for the family, nightmare for the doctor also. But then we all know that the CKD is a progressive disease. It went on rising the creatinine slowly, and by 3 years we were thinking of like, now is the time for transplant. You see that the child came to us with the -3 standard deviation, and at 3 years the weight was -1.43 standard deviation. A great achievement from the family shows their perseverance and the utility of gastrostomy tube, which unfortunately in India is not used that much. Whenever I have counseled family that पेट में एक छेदा किया जाएगा, they have, most of them have preferred not to come back to me, and they have gone to other doctors who most probably have not counseled that, and the family was very happy. So, are we ready for transplant? Yes, mother was ready to donate, but here the question is mainly that size does matter. So you might have heard that size does not matter, but size does matter in pediatric kidney transplantation. Because there are very few centers which are happy to do a transplantation below 15 kilos, and here we were having 12 kilos. But luckily we were having the transplant surgical skills in our unit, and we went ahead with the transplantation, and this is after 2 years. The child celebrating the 5th birthday with a new car. So what does this highlight? It again highlights a lot of things, like medical knowledge, expertise, surgical expertise, all of those barriers which has to be overcome. Moving on to our next child was a meningomyelocele, presented with end-stage kidney disease. But the thing is that this child was diagnosed correctly and was operated within 7 days. But still the child went into end-stage kidney disease, and I think I always say whenever I'm presenting, this is a safe and should be a medical legal problem, like a child moving into end-stage kidney disease from meningomyelocele. Apparently, according to the family, they were never counseled that after repair of the meningomyelocele, you should also be looking after the bladder. And ideally, in most of the good centers, you start CIC right at birth from post meningomyelocele, and at least in our region, this remains something which is still not done routinely. So this is a strong message that if you are dealing with meningomyelocele, make sure that the bladder is looked after. So are we ready for transplant? Father ready to donate, but I'm sure you will be asking what about the kidney, and this what about the bladder? The bladder was a classical neurogenic bladder, small, high pressure, and if you put a kidney into this, then the kidney is gone from the back pressure. So what to do? We can go for the surgical or medical intervention. Medical intervention, CIC, anticholinergics, Botox. Surgical, you can augment the bladder and then put in a mitrophenol. And all this is to make the receptacle normal pressure so the kidney doesn't get lost. So that's what we did in our child, where we did a bladder augmentation with the mitrophenol. We have been dealing with lower urinary tract obstruction. This was presented in IPTA, I think, quite a few years back, and overall they were like when we compared the luto with the lower urinary tract obstruction with the non-luto, there was not much of a difference. But what was the evidence says? Evidence says that if you are transplanting into luto, then be prepared for recurrent UTIs. Evidence says that in short term, luto and non-luto have the same sort of a prognosis. But after few years, transplantation into luto has a faster decline of EGFR, and the neurogenic bladder have the worst prognosis. But that does not mean you should not be transplanted, because remember I said half a loaf is better than no loaf. Moving on to our third child was a child with a WT1 mutation positive, was an infantile nephrotic syndrome who went on to have ESKD, was on CAPD now and was on 4 antihypertensive. So what are the challenges here? Challenges are two things here. One is the WT1 mutation. Now WT1 mutation, if you are a girl and is having XY phenotype, sorry, XY genotype, phenotype girl, XY genotype, XY karyotype, then you are having gonadoblastoma, and also you have a high risk of having Wilms tumor. So that is something you have to keep in mind. You have to keep in mind whether you have to go for a gonadectomy, you have to keep in mind whether you have to go for a pre-transplant nephrectomy. Here the child was XX, so phenotype was the same. Phenotype karyotype was same. So the risk of gonadoblastoma was minimal, so we didn't go that. And the child was beyond 6 years, the risk of Wilms tumor was also less. So we didn't need the transplant nephrectomy for that, but still the child needed the transplant nephrectomy because of the severe hypertension, intractable hypertension, 4 antihypertensive, and then the child did well. Moving on to the fourth case scenario, this was a 9-year-old girl from Bangladesh who came with the FSGS, SRNS, FSGS, ESKD. And a previous child, previous brother, elder brother who had died from some unknown disease. Are we ready? Here the thing I am sure is whether you should be explaining to the family the chances of recurrence post-FSGS. Because post-FSGS there is a 50% chances of recurrence in the graft, and of that almost 50% chances of loss of the graft. And from our studies we have seen, this was a study published from our unit only, small one, but we showed that when the family are counseled that after bachcha ka FSGS hai, we transplant, there is a chance of recurrence, most of the time the family backward. I think what comes into the mind is quite natural. Paisa bhi jayega, kidney bhi jayega, dono hi jayega, so backward. On the other hand, if you have done a genetic study and then proven that it is a genetic underlying cause, then the chances of recurrence are low and the family goes ahead with it. So we did a genetic study, and this was a compound heterozygous for a pole4, and the transplantation was done. Is it done? Mother wanted to donate. Can the mother donate? Latest guideline says that if you are dealing with a pole4 family, better to avoid anyone from the family. So we had to wait for an altruistic donor, the so-called altruistic donor, and a transplant end of will. Last one is a child that came to us with an ejection fraction of 15%, was already on dialysis for 2 years, came to us with very sick, huffing and puffing around, and the child was so distinct that even when she was made to lie, she could not tolerate. So when we were discussing about transplantation in this child, the anesthetist said that better to have a cardiac transplant before we go to the kidney transplant. And the father told me that एक kidney transplant नहीं होता है, heart transplant करके kidney transplant कहाँ से होगा? So the main challenge you can see here, the slowly. Yes. So what we did was that we ran a slow dialysis slate for a number of weeks, and then daily dialysis, and with all that, slowly the ejection fraction improved. This is a good example that yes, in cardiorenal, even type 4, there can be an improvement of the ejection fraction with proper dialysis and proper maintenance. So now the ejection fraction has improved. Are we ready? Even not now. We have stuck the big V of poverty now. The family said that हम लोग तो सब खर्चा कर लिए हैं, सब जगह घूम लिए हैं और खर्चा भी कर लिए. Now we don't have any money. And there was this beautiful publication, Dr. Raja is here and Dr. Jha, showing that in India, just kidney transplantation, even in a government setup, is a huge out-of-pocket expenditure, and you go into poverty. So we needed the help of various NGOs and etc. And then ultimately we were able to transplant the child. And this was really like our whole our unit was there. Help Shakil, Devlina, I think Subhankar was also there during that time. He was involved with the dialysis quite a lot. We used to get a phone call even at night or every time. But this is something that from a no hope we were able to bring back to some hope. So we did just last week we did a very short survey in the pediatric nephrology group in our Eastern India, and involved in pediatric kidney transplantation is only about 1 or 2. Most of us are not involved in pediatric kidney transplantation. 40% of them are referring out of our zone. And when we ask what are the major challenges, all of this, lack of surgical expertise, lack of medical expertise, lack of donor, lack of finance, and 90% believe that lack of awareness about this in the public field. So this is something very important. There are a lot of challenges, but I think sometimes if we can overcome these challenges. So conclusion, among children with ESKD, KT remains. This is I don't think I have to say this to the nephrologist. But even among the adult nephrologists, please don't take me otherwise, we have seen that many a time they have been said that बच्चा बड़ा होगा तो kidney transfer करेंगे. If you are waiting for the बच्चा बड़ा होने तक, then you are missing the growth. You are मेरा बच्चा इतना छोटा या हम अगर इतना छोटा रहे, हम जिंदा रहे तो I don't think I will like to be alive. This is something that we forget, and I personally get very passionate about it. So kidney transplantation remains the optimum mode of KRT. Preparing a child for KT is challenging, but then there are ways out. Thank you very much. And these are some of our young kids who were transplanted.
Thank you, sir, for your presentation and the various case scenarios you have shown, the challenges you faced and how you overcome the challenges. So my one question is, like the government is funding bone marrow transplantation for thalassemia patient, any government aid for renal transplant?
I think there is in this rare disease there is an allocation for kidney transplantation, but at least in our eastern region and in Calcutta,
Provincial government also they are.
No, the government of Bihar is providing up to 4 to 5 lakh for transplant, and post-transplant immunosuppressant are free for the whole life.
Yeah, but there the problem is that most of the government institutions that they are being provided, they are not doing pediatric kidney transplant. Pediatric, मेरा लिए pediatric is not 20 kilo, 30 kilo. मेरा लिए pediatric is 10 kilos, 12 kilos.
But government of Bihar is giving to all its residents whether they do transplant or Patna or Kolkata or Delhi.
So आप लोगों के पास भेजिए हम करते
Yes, sir. And in our, I will say, sir, in our institute at IGMS we have done up to 18 years of this, and I hope in next 4 or 5 years we will definitely do pediatric kidney transplant. So,
in our state, the government is providing 3.5 lakhs, right? And the cabinet has already passed the post-transplant care 2.17 lakhs. So you can add to it. That is what my information. My question to you is, we are doing advisory also. We are recommending body. So you have advocated for API incompatible vis-a-vis paired donation, right? So paired donation, the centers they are doing paired donation, they are advocating for, they are doing better. You are telling that ABI, somebody is telling ABI is better. So is there any universal recommendation you are aware of?
So I am a very small person. All I say is that kidney transplantation is better. ABI ho, jo bhi ho, I want my child to have kidney. Now, as far as guidelines, I don't think anyone will argue that if you have a paired, if you have a living donor who is have a ABI compatible, that is better at the moment than ABI incompatible. इसमें कोई डाउट है नहीं at the patient. But if you are not having the kidney, then ABI incompatible is also good.
That is the controversy. That is the controversy, and that is the irony.
There is no controversy.
The center they are doing ABI. You see, they are showing their data, and they are coming with and they are comparing with the data of paired donation, and they say we are doing better than those people.
I don't know. As far as I remember, there is no.
Your state, you are working.
problem there, because I don't think so. While all the centers are saying that APN compatible is as good, but then the long-term outcomes may not be as good as the compatible ones. So then,
meta-analysis is that only says that after 5 to 7 years it is almost good, but within 5 years it is. I think Dr. Raja will be adding.
I think with respect to ABOs, our results are actually poor, and the rejection rates are easily 2 to 2.5 times higher than an ABO compatible. So always a fair kidney donation it's economical, yes, and also there is no much immunosuppression, and it's going to be.
So my request to Padmasri sir is that he should help us in developing a fair donation program across India and Eastern India.
That is the reason I am raising this question. That is the reason I am raising this question. I am not favoring you or somebody else who is doing ABOI. I know the result. I know the result, but I want an opinion from the house. That's why we can advocate somewhere else, right?
Dr. Rajeev, question that what we feel that this adolescent people or pediatric patients for kidney transplantation, their adherence for difficult to handle. So we have lost 2 of our patients recently. One Jamshed has also been very well with us. The daughter of one magistrate, she went to transplantation at Ganga. There was problem.
Again, this is something very, very good, and from our own series also, like we reviewed it, and most of the, in fact, all of the children that we have lost are from the adolescent with, like they coming with ABMR, ACMR, initially refusing, and then agreeing that yes, we were missing. Like Niladri also was involved with one of those children, and the family generally, the child said that yes, we missed it. And once you get into this ABMR, ACMR circle, with immunosuppressants and everything, then you are gone. And I am not gone, but the child is gone.
Sir, as compared to adult transplantation, what additional workup do you suggest in a pediatric case? And will you recommend genetic testing routinely in all cases, particularly the native kidney disease PGA?
Yeah, sorry, because of time concern, I forgot that. Nowadays, if you are transplanting a child with unknown kidney disease, then you are always doing a genetic workup. Number one, and the other thing that when compared to the adult, but we always do a very comprehensive bladder workup. Very comprehensive bladder workup. It's not that you always intervene on it, but that's something we always do.
Your opinion regarding the immunosuppressive protocol, because you prefer steroid sparing but avoidance.
Ideally, we should be preferring steroid sparing, at least for the first transplant, which is field transplant. I have only done once, but I hope we will be doing it more. AIMS?
We have done 50%. We ended up adding steroids later because of the rejection. So generally,
one thing
we are still following the
One thing I think if we can advocate is that for the pediatric kidney transplant, I don't know about adult, I am very afraid of adults, so I never go near them. So is that if for first kidney transplantation related good match, there is no point in using ATG. We are using basics.
What about EBV screening? Because for PTLD,
we do EBV screening, but I have unfortunately not been involved. Like transplantation was my and is my passion, but unfortunately I have not been involved with that many transplantation. I have been in India. I have done about last time I calculated about 45 to 46. And I haven't seen PTLD in India. In abroad, we were seeing it quite frequently. Sir?
We see PTLD in child transplant. That is again related to the immunosuppression that is being intense immunosuppression more likely to PTLD. Most of our patients are EBV negative.
So that should I haven't seen PTLD in India.
So adding to what Jamshed has asked you regarding the genetic workup, so what genetic workup do you basically suggest? Because there is a whole lot of genetic testing which is available in a child with, let's say, chronic kidney disease of unknown etiology.
So if it is like what we can advise is like you can just write the whole story. The story is very important. The story and the phenotype that should be given to the geneticist. And to that, nowadays with the cost coming down, we are asking for whole exome sequencing.
So whole exome sequencing, almost that package, the typical package people are offering. So the whole exome sequencing of the the genes.
Yeah.
And let's say somebody is having has had a kidney biopsy and the biopsy is suggestive of a TM. So in that cases, you would do only the complement workup or the complement plus?
Because there is not much of a cost difference.
Right.
So we are asking for exome max.
So exome max is the standard which is
that will also include the MLPA.
Right, that is true. MLPA, including MLPA.
The cost is not much. Now they are doing in 11,000 for exome max. Essentially, so they are doing all NGS plus.
So that's why like going into that, it has made life for us easier, not going into like whether to send a targeted panel or not.
There is no more question to conclude this.
Thank you, sir. Thank you all the speakers. This is a different kind of conference. Everyone is asking questions. All the stalwarts of the pediatric nephrology, they are asking questions to all the speakers. So we must congratulate all. Round of applause for all the organizers for such a nice concert, such a nice scientific talk. Moving on, we have the next session, and for chairing that session, we have Dr. Professor A.K. Jaiswal. Sir needs no introduction in the field of pediatrics, but I have to do. Sir is alumni of IAS BHU. After that, worked in NMCH, former HOD of Patna Medical Hospital, and keen interest in the field of pediatric nutrition, helped in the establishment of NRC at the PNCH, at the Center of Excellence. And currently, sir is retired from the PNCH. We welcome Mr. Dr. Dice. We have Dr. Professor Amresh Krishna, Professor and Head of Department, All India Institute of Medical Science and Department of Nephrology, Patna, sir, and Dr. Gyan Prakash, Indian Nephrology School of Patna from the Ford Hospital, Dr. Gyan Prakash. And for speaking this session, I request Dr. Raja Ramchandran. Dr. Raja, sir, please come on the
It is my pleasure and privilege to introduce myself, Dr. Raja Ramchandran, who is an Associate Professor of Nephrology at PGI Chandigarh. Dr. Raja is also the Secretary of the North Zone of ISL, and he is also a member of PDO Working Committee on He has over 400 publications, 200 of them are PubMed indexed. So over to Dr. Raja for his
Thank you, Dr. Amresh. I, on the behalf of Chairperson as well, want to thank the organizers for having me here. The topic is biomarkers in glomerular disease, so I'll try to be as specific as possible and not dwell into too much of basic science. Not that I do not want to discuss that part, because I'm a clinician, so my knowledge regarding the basic science is limited, like most of us over here. So what is a biomarker? A biomarker is a protein, gene, or a metabolic component which reliably indicates either normal health or any pathological condition. So with respect to kidney disease, specifically glomerular disease, why do we need a biomarker? For all practical purposes, kidney biopsy is considered the gold standard for managing kidney diseases. But unfortunately, many glomerular diseases, like IgA nephropathy or FSGS, the kidney biopsy only provides us a static assessment, whereas we need dynamic assessments, like FSGS or an IgA nephropathy that is there today, and 2 years down the lane, which is not therapy responsive, they're going to be completely different. The biopsy is going to evolve, and you can't keep doing a repeat biopsy. That is why you need a biomarker in these clinical conditions. Also, it will be very difficult to distinguish between primary and secondary. Like a membranous nephropathy is secondary to hepatitis B, or because of any complementary medicines, or because of malignancy, would appear the same like a membranous nephropathy, which is seen after any, because of anti-PLA2R related or anti, thrombospondylothorated. And the traditional markers, what are the traditional markers? Urine protein, creatinine, albumin. They are not very sensitive and specific to, detect the disease early. Suppose you have a relapse, the proteinuria is going to take a long time to reflect upon the clinical conditions. So what are the diagnostic markers? What are the type of biomarkers? One is you can have a diagnostic markers. If you want to give an easy example, you have antinephrin now for diagnosis of minimal change disease, and FSGS, you have PLA2R for detection of membranous nephropathy. Then prognostic. Prognostic, if we want to predict disease course, like if you have very high titers of these antibodies, these patients may not respond to only one medicine. You will require a combination of medications, or you will require one medication at more frequent intervals. Then predictive, response to therapy. Suppose you have somebody who has an antibody-mediated disease, and you deplete the antibodies, your probability of having complete remission is much higher than somebody who does not have a depletion of these antibodies. Monitoring. Monitoring is important. Like we were now discussing about, transplant and FSGS. Suppose if somebody has got antinephrin antibodies positive and you is going to undergo a transplant, so now you can wait, deplete the antibodies, get it to negative, and then do a transplant. So these are the uses of the biomarkers. So what actually paved way for research paved way for biomarkers research in nephrology and primarily in glomerular disease is laser microdissection mass spectroscopy. So one towards the left is Lawrence Beck, who had discovered the PLA2R in membranous nephropathy. One towards the right is Sanjeev Sethi, who is an Indian American, and who detected various other antigens in membranous nephropathy and also complement-mediated diseases. So what is laser microdissection? So, if you take the entire Asia as the kidney biopsy, so, dissecting India out of that Asia is nothing but laser microdissection. That is, you dissect the glomeruli out of it. Then mass spectroscopy and proteomics is what, if I have to tell you, look at the proteins and then, do a Western blot and confirm that these are the antibodies which are there. So if, in simple words, so you get into the hall and you look at the type of the chair and the ambience and then decide about what are the quality of people sitting in this room and what is the, the quality of life or the economy of the people. So coming to now, I will discuss about individual diseases. First is photocytopathy, which is common in pediatric setting. Most common, 90% of the patients are having photocytopathies. The pathogenesis of photocytopathy, previously, when I was doing my DM, it was started with a T-cell mediated disease. Then they found that, many of these patients respond well to rituximab therapy. So they thought there is also a B-cell component to it. But now we know that many of these patients have anti-nephrin antibodies. But if you have an antigen and if you have an antibody, you are supposed to pick that on the immunofluorescence microscopy in the kidney biopsy. But that doesn't happen. So the nephrin antibody and nephrin interaction is something different from our traditional antigen-antibody reaction. So nephrin is actually present in the slit diaphragm, the space between two podocytes, and they help in stabilizing the slit diaphragm. They act like a zip. So when the antinephrin antibody binds to the nephrin antigen, you don't have complement activation. What happens is there is phosphorylation of the nephrin antigen. Once there is phosphorylation of the nephrin antigen, the entire antinephrin is being endocytosed into the cell, and then there is disruption of cytoskeleton. And once there is unzipping, what will happen? You will have the podocyte moving away, your widening. So what is called podocyte efface. So this is how you have this antibody-mediated disease. So that is why you don't have immunofluorescence, because the immunofluorescence is not there in the subepithelial space or in the subendothelial space. That is why you have positive. But if you look carefully, you will find that the immunofluorescence, they have a dust-like positivity, that is, they are there inside the podocytes. Because the antibodies are endocytosed, so you may have the antibody showing up on immunofluorescence. So like dust. So if you want to look up how many patients have antinephrin antibodies, so if you look at the adult population, about 40% of the adults with minimal change disease are antinephrin antibodies. With respect to FSGS, it is less, it's 10%. And in children, that is idiopathic nephrotic syndrome, 1/2 of the patients have antibodies to antinephrin. In somebody who has not received therapy at all in idiopathic nephrotic syndrome, it goes up to 90%. they have very good association with disease activity, and they somehow fulfill the cautious postulate. The cautious postulate traditionally is used for infections. So here if you want to use it in an antibody-mediated situation, so you have a clinical condition that is idiopathic nephrotic syndrome or minimal change disease, you have the antibody which appears, you have the antibody disappearing after immunosuppressive therapy and the patient having clinical remission. And if you inoculate the same into experimental animal, mice or rabbit, because in rabbit also there is a cross reactivity with human antinephric and there is development of podocytes. So it completely fulfills the cautious postulate. So how is assessing nephrin antibody useful? One is it can be used to diagnose podocytopathy in somebody who has contraindication, like a child or in an adult who has developed venous thrombosis or arterial thrombosis and you are unable to do a biopsy because of anticoagulation. Second time, sometimes patient may have IgA nephropathy, like you have light microscopy completely normal but immunofluorescence showing IF positivity for IgA. So in these set of patients, if you have antinephrin positivity, you can say that it is most likely minimal change disease. Third one is, like I said, when kidney biopsy will not give you detail. Suppose you have somebody who is going for a transplant. You don't know the basic disease excepting that the patient was treated with steroids probably 7 years ago, I did respond, then he took some complementary medicine, progressed to end-stage kidney disease. So in these situations, if you do a test and if you find that the patient is positive for the antibodies, then it warns you that don't go ahead with transplant without dealing the mess. So, these are the, the clinical aspects of anti-nephrin antibodies. This is commercially not yet available, but I think there are many kits, investigators who are evaluating the commercial ELISA kits and it will soon be available. The next is membranous nephropathy. The one on your left is Lawrence Beck, who had discovered the PLA2R related membranous nephropathy, and it was by laser dissection and mass spectroscopy. PLA2R antigen, like nephrin related to minimal change, this PLA2R is related to membranous nephropathy in 2/3 of the cases. So if you look at the antigen carefully, there are an intracellular portion, transmembrane portion and an extracellular. In extracellular, if you look, there are actually 10 components. These are 10 epitopes. Commonly, the most common antibodies to the cysteine-rich domain, that is CSR is cysteine-rich domain, to which the antibody mostly is focused to. And there are now emerging evidence that if the antibody develops to additional epitopes, the response to treatment is poor. The patient do not have spontaneous remission. Although this is slightly debatable because the data from France says that they carry a poor prognosis, but the data from Germany says that it's more of high titers than the epitopes predict, which is important. But this is all you need to know of the clinical applications. So this is a cartoon or a visual abstract is from the Mayo Clinic, where they evaluated about 97 patients with membranous nephropathy with normal kidney functions, whether there is a need of doing a kidney biopsy. And what they found was, if there is an adult or a child with nephrotic syndrome, normal kidney functions and anti-PLA2 or positivity, by doing a kidney biopsy, you don't make any additional change in the management. So you can get away with the kidney biopsies of these patients. The initial, the recommendation was you can just do PLA2R in patients who have exaggerated risk of harm, like somebody who is not going for a biopsy or having some kind of DVT infections. You can just do a PLA2R and proceed with treatment. Then this was later confirmed in multi-center study in US and Spain, and what they confirmed the same finding that you can do PLA2R antibodies and then get away with kidney biopsy in patients with suspected membranous nephropathy with nephrotic syndrome. So what is, unlike the anti-nephrin antibodies, the PLA2R to prove pathogenicity was very difficult because PLA2R is not easily found in experimental animals. However, recently there are 2 mice and there is 1 mini pig model which has gone on to suggest that PLA2R is pathogenic. Before this, how PLA2R was proven pathogenic is patients with high PLA2R titer and ESRD, when they underwent a kidney transplant, there was recurrence of the disease immediately after transplant, suggesting that this is probably because of the antibody getting absorbed into the new kidney. Anti-PLA2R is associated with kidney disease. You first have antibody going up, then you have the nephrotic syndrome, then the anti-PLA2 coming down because of immunosuppressive therapy, or in 20% it can come down spontaneously, and then you have clinical remission, and with the relapse again you have the antibody appearing early compared to the clinical presentation. So, and in patients with traditionally treatment of membranous nephropathy, we wait for 3 to 6 months before starting immunosuppressive therapy. But now with the wisdom that we have gained, in patients who have PLA2 or titer of more than 100, there is no point in waiting for spontaneous treatment. They are unlikely to remit spontaneously, and you can directly start treatment in them. So when do you test? That is at the time of biopsy, or if you don't want to do biopsy, for the diagnosis of nephrotic syndrome itself. You start a treatment, make sure that you test at 3 months and 6 months, because testing antibodies at 3 and 6 months, predicts the outcome. And suppose the patient does not respond, at 6 months your patient does not respond, you want to start a second line therapy in the next 2 or 3 months, you can do an anti-PLA2. If it is negative, you can wait for some more time, because, the clinical remission, the immunological remission precedes clinical remission by maybe up to 3 to 6 months. So if the patient is positive, you can go ahead and treat. So the same thing with recurrence. 30% of the patients recur. Those with high PLA2R antibodies have recurrence of the disease. So this is the chart showing various antigens. What is relevant in the Indian subcontinent other than the PLA2R is the NEL antigen. The NEL antigen is associated with complementary medicine intake and phase 3, which has got increased mercury in them. So C3 glomerulopathy, most of the evidence comes from the work of Professor Sanjeev Sethi from the Mayo Clinic. So if you look at the complement factor H gene, which is the key regulator of the complement system, that is C3, it has an amino terminal end and a carboxy terminal end. Amino terminal end is present towards your left side and carboxy towards the right side. If there is the carboxy terminal that is towards your right side binds to the surface. So if there is a defect in the carboxy terminal end, you will have endothelial defects or endothelium damage by thrombotic microangiopathy. If you have towards the amino terminal end, you will have something like C3 glomerulopathy. So C3 glomerulopathy and thrombotic microangiopathy are complement-mediated disorders. But in C3 glomerulopathy, the defect is more at the proximal part of the alternate complement pathway. That is why you have, drugs like iptacopan, that is a factor B inhibition, or pegcetacoplan, that is a factor C3 inhibition, the patients respond well to these medications compared to eculizumab, whereas in thrombotic microangiopathy, which is non-anti-CFH related, it is mainly eculizumab based therapy. So coming to the biomarkers of this, biomarkers of the C3 glomerulopathy, that C3b is actually pathogenic, it's an opsonil, and C5b9 is a membrane attack complex which forms podocyte injury and proteinuria. With respect to what kind of test you should be doing in patients with C3 glomerulopathy, C3 is something that we all do in our patients. Alternate pathway functional assay in the form of AH50 and soluble MAC, that is soluble membrane attack complex, that is C5b9. That is something which is there in 60 to 70% of the patients. Other thing that we need to test is C3 nephritic factor, which is unavailable in our country as of now from a validated lab. And anti-CFH can be positive in a small minority of patients. And we have the Professor Pankaj Hari's unit doing anti-CFH. They do it free of cost for us, and we are thankful for that. And it is probably the only validated lab for testing this antibody in the country. So another biomarker that is being used, otherwise traditionally electron microscopy is used to distinguish between dense deposit disease and C3 glomerulopathy. Now we know that EM is not freely available in many centers. You can use apoprotein E as a marker of dense deposit disease. In C3 gene, it's mainly complement. In dense deposit, there is interaction between complement and apoprotein E. This staining on immunohistochemistry can be used to distinguish between the two. The last part is the IgA nephropathy. IgA nephropathy, we know 4-hit hypothesis. IgA nephropathy, you have the gut B cells and the plasma cell which goes to the bone marrow. That is, there is misforming of the gut cells to the bone marrow. They secrete galactose deficient IgA. this galactose deficient IgA is seen as foreign by the body. There is development of IgG antibodies to these IgA antibodies, and there is deposition of IgA and IgG antibodies in the kidneys, and that is the pathogenesis. You don't have IgG, lot of IgG, because there are a lot of IgAs which are bound to one single IgA. That is why you have IgA strong and IgG which is weak in patients with IgA nephropathy. Otherwise, you actually have both IgA and IgG in patients with IgA nephropathy. Histology has been gold standard, but there is a lot of variability between the two observers, even within the same hospital. So this, although it's been called the gold standard, it really has poor reproducibility. And also the correlation with clinical and it's not a dynamic process. And with respect to the prediction tool, there is an IgA prediction tool which is used by the West. It predicts the outcome. However, the adaptability of same in Indian subcontinent is poor. They use the clinical mammography and the biopsy details, and it is poor. Coming to the biomarkers in IgA nephropathy, it's the galactose deficient IgA that is seen positive in 50% of the patient, and it is also elevated in the family members. So it's not a. And they say that if you take more than near about 8,000, it may serve as a marker for the disease. And also people have gone on to assess the galactose deficient IgA antibody, which is there in about 30 to 40% of the patients, and that also lacks satisfactory performance. There are clinical trials that I was involved in, and there they looked at the galactose deficient IgA reduction with use of the newer biologicals. So this is now used as a surrogate also in patients with clinical trials in IgA nephropathy. My last slide is on fibrillary GN. Fibrillary GN, previously it was thought it was probably related to plasma cell dyscrasias. It can be weak combo positive, so there can be confusion with amyloid. If you do an electron microscopy also, you can have 10 to 20 is fibrillary gene, 8 to 12 is amyloid. So then when laser microdissection was done, and what I found was these patients have increased expression of DNA JB9. DNA JB9 helps in the folding and folding of the proteins and clearance of these proteins. However, when there is increased secretion of the DNA JB9, it goes outside the cell and it forms a scaffold on which other proteins come and accumulate in the form of fibrils, and that results in fibrillary gene. There is actually no much antibodies, but these actually antibodies are, the immunoglobulins are also proteins, and they come and get adsorbed on these DNA JB9. That's why you can have IgG positive. You can see smudgy positivity. They don't follow a pattern, it's like smudges, So that is why they say. And there was an analysis that we did from India, which was published last month, where we found that 100% of the patients with fibrillary GN had DNA positivity. So the take-home message was the biomarkers helps in bridging the gap between bench research and bedside application. They have transformed kidney care, like PLA2R antibodies figures the top 10 discoveries in nephrology in the last 20 years, and they help in providing diagnostic precision, prognosis, and also monitoring, like anti-nephrin, especially if you want to do a kidney transplant, if you are thinking about second-line therapy, or if you want to do a genetic testing, it will be useful. Anti-PLA2R has transformed the management of membranous nephropathy. Complement disease is evolving. We are having markers now. With respect to IgA, I think it's damn. We don't have any good markers. We'll have to rely on traditional markers. DNA JB9 for fibrillary gene, or it's an exception in children. We've not seen any children with fibrillary gene. So, the future lies in validating these markers. You may have many markers like C5e9. C5e9 and AH50 can be easily done. But what is important is, the way you transport. You draw a sample testing, you immediately put on ice. If you don't put on ice, there will be complement activation. In a normal person, you will have complement activity C5e9, which is about 10 times that of the normal. So these are all something which is important. And whenever you test for complement, you should always do it from a validated laboratory. Thank you so much. I'm happy to take it.
Thank you, Dr. Raja, for your brilliant lecture. So before asking any question from the audience, I have one query as pediatrician. You have given the disease-specific biomarker, novel biomarkers, I must say, and the traditional market, what we have been doing this like creatinine and your kind of something, blood urine nitrogen, albuminuria, creatinine, albumin creatinine ratio and all. And there is in between your presentation and those days, we have certain other markers like N-cysteine and your NGL and other things, where those tests stand. And pediatrician, general pediatrician I'm asking, because we sometimes go for what that gives the early indication of the kidney disease, like NGL and cystatin and other markers also. So, do we go for those tests routinely, or we rely on creatinine and gradual nitrogen albumin creatinine ratio?
Thank you for that question. If you ask practically, we rely on creatinine. We don't do this NGAL and or even cystatin C in routine clinical follow-ups. NGAL, cystatin C, they are all markers of kidney injuries. In this glomerular disease, most of the patients have normal serum creatinine. So actually, there will be, NGAL and cystatin may not be very helpful. And also, if you look at only serum creatinine and cystatin C, if you look at membranous nephropathy, I think PLA2R is a better marker to know the membranous activity, or antinephrin is a better marker to know the podocyte activity rather than serum creatinine. Like if you want to see nephrotic syndrome, serum albumin may be a better marker than serum creatinine because it goes down quickly, because all these patients have normal kidney function. So hypalbuminemia may actually be a better marker than serum creatinine of the disease activity, not of kidney function, but of the disease activity. So if normal kidney function, there is no much role in NGAL.
Okay. Any questions from the audience? Any query?
Rather, you are doing lots of research in your institution. How do you see the future of transition medicine?
Sir, I think it's a good question. I do not have any direct answers. Like, translation medicine, like 15 years ago, we started translation medicine in PGI. Professor Vivekananda was also from PMCH. He initially headed the department, and we took over. Most of the work that I do is from his lab only. Like, after his left also, he continues to support us. So there is a long way. I think the future is into these biomarkers. I think nephrology is transforming. Why I say it is transforming? See, previously 10 years ago, the conventional therapy was always steroids, MMF, tacrolimus. These were our medications. More than actually the disease, we were actually treating them as immunosuppressive specific diseases. But now you have biological markers, you have biological agents that for IgA you are having specific agents, for complement mediators you are having specific agents, for membranous nephropathy you are literally evolved from steroids and cyclophosphamide and gone to rituximab and obinutuzumab as a primary therapy. So I think we are evolving, and the future is into translational space.
Moreover, all the classifications are changing, and that's why the line of management is also changing.
Yes.
That is very important. Yes. And it is interesting.
Yeah, we are moving from pattern, like MPGM means we used to go by pattern, like whether it is chronic TMA or immune complex CNS. Now we are going more into etiology specific. Once you go to etiology specific, then you just target the etiology and treat them that way.
Thank you. Thank you very much. And this is supposed to be your talk tomorrow in a plenary, but then I think we have got quite a lot of audience today also. I have got a comment and a couple of questions. A comment is for the membranous nephropathy in pediatrics. I have been doing a plaque quite religiously, but just out of my mind, I think we have seen about 14 or 15 non-lupus membranous lupus, and I can remember only one. What is your experience in pediatric? And Dr. Pankaj can also add.
So now I have a follow-up of 1,000 patients. So we run a registry. I've been running this for the last 15 years. And we have 1,000 plus patients. And 100 of them are adolescent or children. So, I take up till 18, so, pardon me for that. So, and most of them who are less than 10 years, the incidence of PLA2R related disease is less. Whereas in those who are in between, that 13 to 18, they are somewhat similar to adult age.
Yeah, interestingly, that one positive was about 14 years.
Yeah, that's it's probably 13, 14 years, then it's like the adult.
But do you do this routinely, all the antibodies, and now only just plaque-2R, or now they have come up with anti-sponding and
the pathologists would tell us the report is positive, but plaque-2R would be in both pathology as well as serum creatinine routinely for all NGs.
And apart from plaque-2R?
The rest of them are not being done as of now.
This is the problem. There are commercial laboratories, large pathology without taking name. I know, but so they do all the antibody testing, but probably they have a bulk, so it's easy for them to procure. For PJ, procurement is difficult. To be honest with you, procurement process is very tedious. So we barely do PLA2R testing. Nell is also done as a part of research.
Like, should we be asking for that from the last panel, the full panel?
So if they're doing it reliably, then you but then the cost is there.
Should it be, like, my question is that should it be a routine for us? Like, if the cost is not, like if the family is agreeing to that, then should we be asking for the whole panel? In pediatric age group.
So in any age group, like money is not the question, and anyway you're not going to take any additional tissue for that. So that it's always nice to have the full workup, sir. And they do it sequentially. Like you do PLA2R positivity, they will stop there. They will not test for the other antibodies. They will only test for other antibodies and PLA2R is negative. So if money is not an issue, it's good to have the complete comprehensive workup.
Because like your statement of that biopsy not being useful, I think that will be more restricted for the a bit elder age.
Sir, biopsy not useful. I should not be misquoted, sir. Biopsy is not useful in somebody like IgA nephropathy or steroid-resistant FSGS, where 2 years down the lane, the disease is going to be much worse histologically compared to what it is today. With membranous and MCD, if they treat and respond, you know that the disease will not be that bad even after 10 years.
Because what I understand is that in adult practice for membranous, I don't think we are doing biopsy anymore. If the platoon is positive or against
the recommendations, if you want to understand more holistically, in America, the biopsies are done by intervention radiologists. And in India, it is done by nephrologists. So, first thing is you have to understand food on the plate. For us, it's food on the plate. So, and we do biopsies to diagnose membranous nephropathy. We use anti-PLA2R for treatment. Exactly. Because it's 4,000, 5,000, 4,000. If it's available even in PGI, the cost of PLA2R is 2,000 rupees. Whereas to get TT biopsy is almost close to free of cost.
Now, coming to the question that I had, it was about the anti-nephrin antibody. So this anti-nephrin antibody has a lot of hype that we have now come up with a very new molecule. But my understanding, is it correct that it has been shown that it is usually for the steroid-sensitive nephrotic syndrome rather than for the steroid-resistant nephrotic syndrome? So if it is for the steroid-sensitive nephrotic syndrome, then how are we going to use it in the algorithm? Pankaj is already saying he seems quite disappointed after his super experience.
Because I think the same thing happened with Super, and he tried doing this anti-nephrin and there's a project going on. Okay. So the results are not very encouraging. So I really don't know whether this and APOE will be truly biomarker that will be replacing, or they will be just dying out like Super.
Exactly. Super, I think, is what we understand is more a marker of chronic kidney disease progression than actually, these photocytopathies. The anti-nephrin antibodies testing is the problem with anti-nephrin antibodies, the challenge in doing it. With respect to steroid-resistant FSGS, we said, they said 17% of the patients who had anti-nephrin antibodies and steroid-resistant FSGS, they had recurrence after transplant. Whereas none of the patients with genetic associated FSGS had recurrence post-transplant. So with respect to, you say that, is it useful or not? Suppose you give steroids and the patient, exactly, sir. You take another example. You give steroids alone for a patient does not respond. You do an anti-nephrin and if it is positive, you can give rituximab. They show that you give rituximab. One shot of rituximab, antibody comes down, the PLA2R also comes down, the clinical response also comes down in another 3 months. So I think we are learning, sir. It's close to only 1.5 years of what we know. But it looks promising, but again, only time will tell how promising. We should have a commercial, ELISA, which is easy to do, because all these tests, the ease is more important. You can't have something which is very challenging and expect that, everybody will be doing it.
And my last comment, I'll give the mic to you also. And the last comment is like, and this is something that I have been saying in all the forum recently, like with the eczema coming into the market, it is high time that the higher ups should make sure that we have got this anti-complement factor, each antibody testing facilities in each zone of India at least.
Yeah.
Because otherwise, as well as all those complement markers, otherwise I am 100% sure there will be a lot of use of eczema, maybe when it is not even required.
So 3 points I would like to make. I'm sorry if I'm crossing the time, sir. So the one point is about the anti-CFH. There is commercial kits which are available for anti-CFH testing, and I have also used that kit. And the problem is in the complement KTO complement discussions when we did, it is largely accepted that we should not be going by that kit. So we should be doing by a well-validated lab. That is, the pediatric nephrology at All India Institute is doing a wonderful job, and they have
One center cannot cover the whole of India.
I agree, sir. You should have it, and probably, he will take the responsibility of training others. So that is left to him. That one is the laboratory part. The second part is clinician's part. Whenever you send a sample, not for anti-CFH testing, for C5B9, AH50, you need to make sure that when you draw the sample, you need to immediately put them on the ice. So that is important, and you need to transfer them on ice only, because otherwise you will have false report. And the third one is with respect to use of eculizumab. You should all remember that if there are 50 people sitting in this room, 40% of them will have heterozygous deletion for CFHR1 and 3. So please don't treat CFHR1 and 3 heterozygous deletion. If there is homozygous deletion, it is only relevant if there is presence of anti-CFH antibodies.
That's what I am afraid of, that with the eczema coming up, there will be a lot of use.
Sir, in continuation with Dr. Adit's question regarding anti-Cl2, you said as we don't see too many cases of membranous nephropathy in pediatric group, but it's recommended, or most of the guidelines say that we should be going for this anti-Cl2 and anti-HDH7 antibodies. But my question is, you said it is basically used for treatment, monitoring.
We do it.
Yeah. So suppose we have, because I recently had a patient where the serum anti-Cl2 antibody was negative and tissue was positive for anti-PLA2R. Because of that same phenomenon that we know. But in that case, the problem is, suppose the baseline anti-Cl2 antibody is negative, how do we monitor? Well, the second dose of immunosuppression is required because we don't know what is the baseline serum anti-Cl2 antibody. So how do we progress in that case?
We were instrumental in reporting the same phenomenon for the first time. So if there is tissue positivity and the serum is negative, there can be two causes. One is immunological remissions happen and clinical remission follows after that. So the patient has probably had immunological remission. Clinical remission will follow after some time. The second one is you have an antibody which immediately after production goes and gets deposited in the kidney, or it's a low titer antibody, what you call as a sink phenomenon. Like you have in kidney transplant, you have donor specific antibody getting absorbed into the kidney. You have the anti-PLA2R which goes in the kidney, serum is undetected. So in these patients, when you repeat the PLA2R after probably 3 months or 6 months, you will show positivity. So that is how it is. In a very, very small tiny minority, you will find that same phenomenon is happening continuously for a prolonged period of time. There you will have to base your judgment based on clinical assessment.
A comment and a question. Comment was about steroid-resistant nephrotic syndrome and recurrence. One recurrence, if a genetic one's obviously recurrence is very minimal. If it's a non-genetic one's recurrence, especially the rapid progression in steroid recurrence rate is very high. Whether it is nephrin-related, non-nephrin-related, or something which is not found out circulating factors, it could be. So just to say that nephrin positive relapses in 70%, you can only say that if you have a cohort in which non-genetic cases, rapid progresses of steroid-resistant nephrotic syndrome who are non-nephrin. So then you can do head-to-head, then you can say that overall what it says is, if it is non-genetic recurrence, especially someone who progresses within 3 years to end-stage kidney disease, recurrence rate is high, out of which one they found out to be nephrin. Overall the recurrence rate is high in that. So that's one comment. Second thing is,
most of us use this APNEICON as a marker for a treatment, definitely. But if I'm going for a transplant and the marker is continuously positive despite multiple doses of returns, other therapies, it's not coming down, but my serum IgG levels are going negligible. So how much do you chase it, or when do you say, let me stop chasing that?
I'll pick up the easy question. Your second question is largely speculative, in the sense that, it's a situation which generally does not.
No, they have a case.
I'm trying to tell you that it doesn't happen that way. You have an ESRD patient, he will have antibody, you give a shot of rituximab, they generally come down by 3 months. It doesn't happen that they stay very long, because ESRD itself is an immunosuppressive condition. Second one, with respect to your first question on antinephrin, malignant FSGS, what we call as those FSGS which go into ESRD within 3 years of age. In pre-nephrin era, the most important predictor of recurrence in FSGS is history of steroid sensitivity. Like if somebody had history of steroid sensitivity, he had the maximum probability of recurrence rather than even more than what 3 years or 2 years, whatever number you give. Coming to second one, whether these antibodies are going to be helpful or not, there is a study which is published in Kidney International from Japan, where they went on to show that 80% of the patients who had recurrence of FSGS post-transplant were antinephrin related. So I think there is a role, but this is evolving. This is just 1.5 years of antinephrin. We need to get better, but there is clearly a role that it is pathogenic. Unlike PLA2R, it was very difficult to prove the pathogenicity of PLA2R. Whereas with nephrin, there is a clear-cut animal model also to suggest that it is pathogenic.
I will request all the speakers and all the chairperson to please come forward and the presentation. Next we have Dr. Sakil Akhtar. He will present about academic activity 2024-25, and I will request Dr. Sakil to come on.
Good evening, everybody, and thank you very much. I must thank the organizers for inviting me here, and on a personal note also, I was born and brought up here, so it's like getting back to roots. So thank you, Patna, for this wonderful journey. And also, it has been a very wonderful academic evening. I hope tomorrow it will be the same, and I must congratulate the local organizing team for hosting this. Thank you very much, and let's come to the APNEICON activities that we have been doing. APNEICON was first formed in 2017, and since then it's been the 8th year of its formation, and it's been growing from strength to strength. We have some our own Eastern India pediatric nephrologists, and we are very proud that a lot of activities have been going around. And in the past year, I'll be just discussing what has been happening. Now, because this is the host state, and then we would like to start here on. From the AIMS Patna, there have been a lot of good ongoing research projects that have been happening. Like this has been shared from Dr. Soni. The research projects based on machine learning enabled mobile applications for urine dipstick analysis and compliance tracking and nephrotic syndrome looks very interesting. And then there are profiles, pathological profile for pediatric renal biopsies in this part of the country, identifying the cause and clinical outcome of patients receiving RRT. And there's also a study on the single center observational study to explore genetic etiology in children and young adults suspected to have monogenic CKD from this eastern part of the country. Also, there are a few publications that has already been there, and the work on infolding globulopathy, which was reported first as a novel case report in pediatric nephrology, and then the case series has come up from AIMS Patna. That again was published in nephrology. Also, there is another publications which deals with the familial renal glucosuria, which presented as recurrent urinary tract infections. And there are also some of the publications that are under review and under the pipeline, and mainly dealing with the spectrum of renal disease in adolescents. And this one of posted, I guess. There are a few studies on atypical India. There are also posters on atypical hemolytic HUS presenting as steroid resistant nephrotic syndrome. Looks interesting. And also there are some more interesting spectrum on C3 glomerulopathy, histopathological spectrum on renal biopsies in pediatric age group, and integrating genetic testing in pediatric kidney disease, spectrum of renal disease and